Yes, sir is there. Shall we begin? So, good morning, all of you. Welcome to the second day of the Diabetica 2022. Hope that you had enjoyed Statue of Unity yesterday, and let's begin our first session. For the first session, I welcome our chairperson, Dr. Rajesh Parvadia from the Amreli and Dr. Manish Lad from the Silvassa. So, let's hope for the best academic session today also. And over to you, chairpersons. May I request all the speakers to stay with the time so that we can finish out on the time. Thank you.
Good morning, friends. I invite Dr. Akash Singh. He's a senior consultant medicine diabetology in Vadodara, president Indian Diabetes and Cardiometabolic Disease Association. He'll be talking on evolving evidence with newer DPP4 evogliptin.
Yes, yes. Yes, yes. CV મૂકી દે ને CV છે કંઈ વાંધો નહીં અહીંયા CV ચલાવી દે ને પહેલાં બસ સર થઈ ગયું બસ ડન આપી દે પ્રિવ્યુ ટાઈમ મોકલ સ્લાઇડ આપી દે Yes, after switch on. Done.
Good morning, everybody. Today I'll be talking about evolving evidence with newer DPP inhibitors. The new DPP inhibitor on the block is evogliptin. Introduction about this molecule. This molecule is basically an efficacious molecule, a newer DPP4 inhibitor, but this molecule has evolved from South Korea basically. So this is a South Korean molecule. So it is a selective, potent, reversible inhibitor of DPP4 enzyme, extensively studied for its efficacy and safety, and it is approved in South Korea, Azerbaijan, Russia, Bolivia, and in India after extensive trials by DGCA. Now all DPP4s, are they all same basically? Definitely not so, because the efficacy of DPP4 inhibition is measured by round the clock efficacy of DPP4 enzyme, and round the clock efficacy of DPP4 enzyme should be at least 80% to call it a efficacious molecule, and this 80% is not achieved by some of the molecules which are present in the market. So we have several DPP4 binding sites, S2 extensive site, S2 S1 site, and S1 dash and S2 dash side basically. Now binding with S1 and S2 is considered as fundamental binding and is required to produce DP4 inhibition. Binding to additional sites like S1 dash, S2 dash and S2 extensive produces more inhibition of DPP4. Now if you see the molecules like sitagliptin, telgliptin, evogliptin, they are basically binding to S1, S2 and S2 extensive sites basically. And alogliptin and linagliptin are having additional binding to S1 dash and S2 dash. So the binding of evogliptin to S1, S2 and S2 extensive is non-covalent binding, is irreversible binding. It reaches plasma concentration in 3 to 5.5 hours. Plasma DP4 inhibition rapidly surpasses 80% in less than an hour. It's a long half-life. Elimination half-life is 32.5 to 39.8 hours. Reaches a steady state concentration within 3 days. It is basically not an inducer of cytochrome P450 enzyme, and it is not also inhibiting the other enzymes on the cytochrome pathways, but its metabolism is primarily mediated through cytochrome 3A4 enzyme. Renal clearance and fractional excreted unchanged urine is 27 to 34% of evogliptin. So no dose adjustment was required because urinary excretion is not the major pathway for elimination of evogliptin. Dosage and administration adjustment is not needed in patients with mild to moderate hepatic impairment. So mild to moderate hepatic impairment safe, and in renal disease it is safe basically. So if we summarize, we have more than 80% DPP4 inhibition over 24 hours. The postprandial GLP-1 levels increase. There is a 1.5 to 2.4 times increase. This is decrease is wrongly done. There is increase in GLP levels in the postprandial state, and postprandial glucose levels decrease by 20 to 35% by this molecule. Now this was a international study. The first study you do is to study the efficacy of the molecule, and this was studied in patients with HbA1c, baseline HbA1c of 7.2, which is very low HbA1c, and you do not expect a very robust decrease in HbA1c at this level of HbA1c by addition of any molecule. So you can see that almost there is a minus 0.23% decrease in HbA1c compared to placebo. So this suggests that evogliptin 5 mg monotherapy significantly decreased HbA1c levels and was well tolerated in patients with type 2 diabetes, inadequately controlled on diet and exercise. Now coming to efficacy and safety of evogliptin treatment of type 2 diabetes mellitus, this is a Brazilian study, and they have compared different strengths 2.55 and 10 mg strength in comparison to sitagliptin basically, and you can see that once daily treatment with evogliptin 5 mg was safe and well tolerated. Most frequently reported adverse effects were similar to those observed with other DPP4 inhibitors. So it is almost equipotent compared to sitagliptin, which is the gold standard for comparing the DPP4 inhibitors. Now evergreen study objective evaluate efficacy and safety of evogliptin versus linagliptin, and here they had a run-in period of 2 weeks, and 1-to-1 randomization was there, and during 2 weeks to 12 weeks one lot was allotted to evogliptin 5 mg. They studied the efficacy of this molecule. They found that the HbA1c reduction were similar in both the linagliptin group as well as the evogliptin group. So this clearly suggests that it is an equipotent molecule, and linagliptin and evogliptin carry the same level of efficacy. The study was conducted for 24 weeks. So the glycemic variability was also considerably decreased. Both parameters, the MAGE and the standard deviation, was decreased basically, and there was a good control of blood sugars with the use of evogliptin in this study, and all the parameters related to good control of diabetes, like the fasting, the postprandial sugars, the HbA1c, the glycemic variability, and hypoglycemia. Everything was basically taken care of in a good fashion with evogliptin. So when evogliptin was orally administered for 12 weeks in type 2 diabetic patients, the mean change of HbA1c in evogliptin 5 mg group and linaprazan 5 mg group was minus 8.5 and minus 7.5 respectively, proved to be non-inferior to linaprazan. In glycemic target goal, proportion of subjects with HbA1c less than 7 and less than 6.5 at week 4 was 80.22% and 48.35%. So a very large chunk of patients received got to the goal of less than 7 HbA1c. 24-week study evogliptin is considered to be a safe and effective anti-diabetic treatment for type 2 diabetic patients who have insufficient blood glucose control through exercise and diet therapy without any significant adverse events. After 24 weeks administration, evogliptin also resulted in an improved glycemic variability measured by continuous glucose monitoring, and a statistically significant increase was observed in proportion of time in appropriate glucose range. So the TIR also improved very significantly. Now coming to study in renal dysfunction, and here 32 patients were studied, and they were given the same dose of evogliptin, that is 5 mg OD, and drug was found safe in all grades of kidney dysfunction, so you can use it safely in patients with renal impairment. Now coming to patients with hepatic impairment, and in hepatic impairment also, they basically these are always small studies basically, but they tried this drug in patients with mild and moderate hepatic impairment vis-a-vis healthy controls, and in both the groups, mild hepatic impairment, moderate hepatic impairment, they had a healthy control also, and dosage and administration adjustment is not needed in patients with mild to moderate hepatic impairment with the use of evogliptin basically. So you can give it in mild to moderate hepatic impairment. Now efficacy and safety of evogliptin in patients with type 2 diabetes and NAFLD. This was a 24 weeks double-blind, active control, randomized, parallel phase 4 clinical trial in South Korea, and mean age patients was 52.33 plus or minus 11.31 years, and 33 participants were male. Mean BMI was 28.61 plus or minus 3.82. Approximately 80% of the study participants had moderate to severe liver disease. An effect on hepatic fat content was measured using the gold standard of MRI PDFF, and they saw that there was a marginal decrease in hepatic fat content and absolute fat content in this group, which was not very statistically significant, but definitely there was a marginal decrease. This 24 weeks trials demonstrated that evogliptin was safe and showed a trend in reducing liver fat for patients with type 2 diabetes and NAFLD. So this patient is a good add-on drug basically for use in NAFLD. Cardiovascular risk in patients treated with evogliptin for type 2 diabetes, nationwide population-based cohort in South Korea, and the objective was to evaluate the association of evogliptin use and risk of cardiovascular disease when compared to other second-line anti-diabetic patients in type 2 diabetes. It was compared to DPP-4 inhibitors, and it was compared to the other drugs, basically metformin and all. And the exploratory objectives were to describe the demographic and clinical characteristics of patients with type 2 diabetes treated with glimepiride, DPP-4 inhibitors and SGLT2 inhibitors as second-line treatments in South Korea. And you can see this is a very large study, basically almost 7 lakhs plus patients were included in this study, and they were given different drugs and studied basically, and they concluded that amongst 1,39,551 incident type 2 diabetic patients on metformin monotherapy, approximately 1 lakh patients added or switched to DPP-4 inhibitors, where 2,946 were users of evogliptin. Compared to glimepiride used, DPP-4 inhibitors users were associated with decreased risk of cardiovascular disease. SGLT2 inhibitors users had a null association. Compared to glimepiride users, evogliptin users were associated with decreased risk of CVD, cerebrovascular events. So the use of evogliptin either decreased the risk of CVD or had no association with it compared to other ingredients or DPP-4 inhibitors or SGLT2 inhibitors. So this was very safe as far as the CVD part is concerned. Now coming to evagliptin plus metformin, the efficacy and safety of metformin and evagliptin combination basically, and they studied it through various trials conducted in Korea, in India, and various other trials basically elsewhere which are published. An international study in Korean population, it suggested that evagliptin 5 mg added to metformin 1000 mg therapy improved glycemic control and was well tolerated subjects with type 2 diabetes, and thus was not inferior to sitagliptin. In Indian population, again evagliptin 5 mg was effective, safe, and non-inferior to sitagliptin as add-on therapy to metformin 1000 mg in Indian patients with type 2 diabetes. A multinational global study again concluded that when added to metformin 1000 mg or more than 1000 mg, evagliptin demonstrated non-inferiority compared to sitagliptin in terms of HbA1c reduction at week 24. Now coming to the safety of evagliptin, the safety studies also have been done. Basically, several safety studies are available, and the forest plot is highlighting the side effect profile of evagliptin, and it is comparable to other DPP-4 inhibitors. It is having no additional side effects. Now evagliptin and evagliptin plus metformin, the latest Indian data from 2020 to 2021, and this data is conclusively showing that evagliptin was found to be effective when added to patients who were uncontrolled on dual or triple oral anti-diabetic medications, and even in treatment naive patients. So the Indian data, the continuous glucose monitoring data, this was again a study which was presented at RSSGI 2020 with the aim of assessing the efficacy of evagliptin 5 mg through continued glucose monitoring in patients with type 2 diabetes in retrospective observational real world settings. So the results were that evagliptin was found to be effective when added to patients who were uncontrolled on other oral anti-diabetic medications. Its efficacy, it effectively showed improvement in continuous glucose monitoring parameters like mean blood glucose. More number of patients were in time in range after addition of evagliptin to existing anti-diabetic medications. So a well-tolerated drug, efficacious drug, and drug you can use for all occasions in all type of patients. Efficacy and safety of evagliptin plus metformin add-on to insulin therapy in elderly Indian diabetic patients with type 2 diabetes, and here again you can see a very good reduction of HbA1c from 8.4 to 7.2, which is very good basically from the point of view of any drug basically. So the CGM analysis revealed that standard deviation and more than 180 mg per deciliter were significantly decreased, and hypoglycemic events were not increased, and furthermore 22% of patients with suboptimal glycemic control achieved composite outcome consisting of improvement in HbA1c, weight loss, and insulin dose reduction. So again this study showed that it is an effective molecule. Effect of evagliptin as add-on to type 2 diabetic patients inadequately control of metformin and glimepiride combination, and the results were again showing that this is efficacious in getting the patients to goal and to have the patients achieve the HbA1c levels of 7% or less. So these are the other various post-marketing studies which again show the same, that FDC of evagliptin plus metformin film-coated bilateral effectively reduced HbA1c fasting and post-prandial levels. The combination was safe and well tolerated. So in summary, truly once a day, due to its longest half-life of 32.5 to 39.8 hours, established renal, hepatic, and CV safety without need of any dosage titration. As per Evergreen study, 24-hour study versus linagliptin, evagliptin is shown to have highest reduction in glycemic variability as compared to linagliptin, and HbA1c reduction was proven to be non-inferior versus linagliptin. With 3 head-to-head studies against sitagliptin, evagliptin is also proven to be non-inferior to sitagliptin, one of which was Indian study, that is Evolution India. Evagliptin plus metformin combination, FDC formulation, provides better compliance with convenient administration, a strong OD dose rational compared to immediate release. Thank you very much.
Thank you, Akash sir. Question from the audience.
I know that basically it is now a choice basically which is more of a jugglery, because sitagliptin is as such a gold standard for DB4 emitters, and now with the price being reduced to almost 20 to 25 rupees for sitagliptin 2 basically, this will become a very sort of more of a commercial decision. This is also a good drug basically, but I am definitely against uses of tenagliptin or vildagliptin in OD dosing, because tenagliptin is having a very less 63 or 64% DP4 inhibitors at the end of 24 hours, and also saxagliptin also has lesser DP4 inhibitor, and that is around 73% by 24 hours. So apart from these two drugs, all the drugs, vildagliptin, BD dosing, or sustainably OD dosing, and other drugs, linagliptin, all are comparable basically. So the uses will be more of based on the sort of commercial this thing, rather than on any scientific this thing, because all are equally equipotent.
There were large data which you had shown with the hemoglobin, the real world data, which found that patient with the sulfonylurea found to have more function or the coronary artery disease in compared to the patients who are on gliptin, and then out of them some gliptin of 2000 patients were on hemoglobin also. So don't you think that what happens in the real world data, this is the data which Korea had collected, because everything is on electronic medical records. So you will start your patient with the metformin, then you will put the patients on the metformin and gliptin, and then patients will be put on the metformin and sulfonylurea, metformin, gliptin and sulfonylurea. So a patient who is already started on sulfonylurea, he is already having a 10 years of diabetes, may have a bad glycemic control, and he is having long duration of diabetes. Now after 5 years you wanted to see all past data of these patients. So what you will find, the patients who are already on metformin, metformin and gliptins, and only on metformin sulfonylurea. Naturally in these three groups, you will find the patient who will develop more myocardial infarction. The patient who is already put on the sulfonylurea, because they are already longer duration of diabetes. They have bad glycemic legacy, and they are the one now going to have more coronary artery disease in compared to a patient who is only on metformin. So the cross-section data is taken like this, that 5 lakh patients of, like, suppose we from Ahmedabad, Baroda, or from Gujarat, we just wanted to see all our patients of last 15 years, 20 years. You are not taking consideration that patients who are put already on sulfonylurea, they have already a longer duration of diabetes, and now they will have more chances of coronary in compared to. So sometimes, the sulfonylurea is blamed for more coronary artery disease with this type of retrospective data collection, which is not like a prospective control trial.
Actually, what I feel is that data collection may be anything, but once the sort of analysis is done, so the analysis will manipulate the data to suit the intention of the study.
No, they
So
might
the
have done the perfectly, the way the analysis has been done. You try to understand that, you have 5 lakhs patient. Now out of 5 lakh patients, how many patients are on glimepiride metformin, how many patients are on gliptin metformin, how many patients are on only metformin, how many patients are only on SGLT2, and you will try to analyze. And today you will see that how many of them have developed a coronary artery disease. So the patient who has been started on sulfonylurea, who are the one? They have already the longer duration of diabetes, they have already 5-10 years of diabetes, they have bad glycemic legacy, and they are started at the age when somebody was at the 50, now they are 60, and then they put on sulfonylurea. So the person at the age of 60 are more chance to develop a coronary artery disease in compared to a person who is started at the metformin with, only on metformin.
Any other questions from the audience? Thank you, sir.
So our next lecturer is Dr. Yash Patel. He is experienced consultant with demonstrated history of working in health, wellness and fitness industry. He will be talking about ripaglinide today, impactful weapon against the postprandial hyperglycemia.
Thank you all chairperson, to the organizers, to the conference Diabetica 2022. It is indeed pleasure to be here and to interact with all of you, and pleasure that this is taken into the both platform. So yes, the delegates available over here and the digital delegates, we welcome you for this wonderful conference, and it is pleasure to address you this talk, Repaglinide, impactful weapon against postprandial hyperglycemia. So to that note, I really acknowledge the organizing team as well as the disclosures of mine is none for this talk, and to lead this talk further way ahead, we would see the introduction, why diabetes is a global as well as Indian scenario, glycemic pentad, then current availability therapies of management in postprandial hyperglycemia. So we have talk on the three aspects: diabetes, postprandial hyperglycemia, and what are the choices of postprandial hyperglycemia and where repaglinide stands for the same. In that note, we know diabetic epidemics all over around, 9.3% prevalence all over globe, along with 463 million diabetics who are at present going through this lifestyle based scenarios. In Indian scenario, yes, our registry is somewhat at question, but we have at present 8.9% prevalence with 77 diabetic population going through. Why Indians are so different than the global community, that's what we will address through, and why it is needed to be addressed is we are the second largest community who are going through. So from glycemic pentad to look for, first we see the glycemic triad, that is fasting, postprandial and HbA1c. So glycemic pentad, now it's basically based further to the hypoglycemia as well as glycemic variability. To that note, today what we are focusing is specifically postprandial plasma glucose, where we would look for, and in Indian scenario what we see is almost 12 to 16 hours of postprandial state of an Indian community, of an individual, is really what we are looking around. So if we see our Indian meals, breakfast, lunch, dinner, and the common stage of postprandial is postprandial, post-absorptive, and then going to the fasting. If we see the 24 hour span, breakfast, lunch, dinner, the fasting stage almost comes from midnight to the early morning or till the breakfast is there, and that's a really short period, and where Indian community contributes almost major part of the postprandial control required for the HbA1c target to achieve. Now insulin secretion after the meal, if we see the first phase and the second phase, and this is common physiology we have encountered. In that note, why first phase is important, that contributes the major postprandial stage, and that bluntings happen in the early part of the any diabetic individuals, and that's the 2 minutes of food ingestion, where and it continues till the 10 to 15 minutes. So loss of first phase is specifically developed in type 2 diabetes and contribute to the postprandial hyperglycemia. If we see the Indian scenario, what we have seen, the different diets in the different regions, we have almost 353 officially registered language in India, and I don't know how many food patterns would be registered if we start registering those things around. But what we found out commonly is almost 64.1% of total energy consumed in diet is contributed by carbohydrate. Where about is similar finding across all zone of India is present, and the carbohydrate consumption is much more higher, and that contributes almost postprandial stage of all diabetic individuals available in India. Almost 62.5% diabetic populations go beyond target of 180 milligram per deciliter, and that's why inadequate glycemic control in diabetic patient might be related to higher dietary carbohydrate consumption among the others global level. Now UKPD studies, we have seen HbA1c is equal to fasting in postprandial, where initially thought of fasting is majorly contributed to A1C, but looking into recent studies, postprandial also contribute in that extent, and these excursions are much more important on both the side, and that contribute to the CVD as well as the mortalities. Now to the better control, if we see the newly diagnosed individuals where the A1C is between 7 to 8.5, and when we see this graph where we thought of that postprandial is one of the great contributor to the newly type 2 diabetic individuals, and that's range from 7 to 8.5. So looking into these individuals where early contribution to reduce the A1C is taken care by postprandial excursions to correct for. Now the key question for managing the postprandial hyperglycemia is postprandial hyperglycemia is harmful. Why is it important to control postprandial hyperglycemia? What are the current available modalities where we can use to manage this postprandial hyperglycemia, what are the limitations for the same, and what could be the solution for upcoming time. So coming to the harmfulness of postprandial excursions is, we know macrovascular complications along with intima media thickness and myocardial blood volume as well as blood flow is contributed to that level and affected in that line. Even the oxidative stress as well as inflammation and endothelial dysfunction is one of the line where we should think of postprandial hyperglycemia affecting those levels. So uncontrolled postprandial hyperglycemia may lead to serious consequences, and we know that could be from the dyslipidemia to the inflammations to the endothelial dysfunctions, plaque dislocations to fibrinolytic activities to other markers in the metabolic diseases as well. So excessive postprandial hyperglycemia is where we should focus, and what guidelines says differently, what could be the control of postprandial hyperglycemia. If we see the IDF, it asks for to make it to goal 160 below. If we see A is then less than 140, yes, ADA 180, ESD is much more aggressive to keep below 135, and RSSDI our guidelines says below 160, and that's where postprandial after 1 to 2 hours of a meal, SMPG should be considered for the postprandial monitoring to make sure these goals are act on or addressed to. Now, if we see this slide, what are the modalities we have at present? Oral or non-insulin injectables, anti-diabetic drugs approved for and the treatment of type 2 diabetes. And if we see who are the major contributors who can support postprandial above the fasting. So that's where glinides, alpha glucose inhibitors, DP4 inhibitors, GLP-1s and amylin analogs. Where amylins we don't use much more in the Indian scenario, and we have not commercially available it to that extent. So what are the choice? If we see oral, glinides, alpha glucose inhibitor and DP4 inhibitors. Where GLP injectable and now onwards the oral in same extent. What are the limitations? As we saw into that postprandial glycemia management, where we focused, and what we have choice is alpha glucose inhibitors, glinides and DP4 inhibitor. If we see specifically focused to today's talk is also, if we see glinides, then risk of hypoglycemia and weight gain compared to alpha glucose inhibitors and sulfonylurea is much more limited to the extent what it has been seen. If we see alpha glucose inhibitor, glucose GI disturbances including diarrhea, abdominal cramping and flatulence. Yes, Indian scenario we don't mind to get PAD, but in American and Europe scenario it is really social concern to look for, and that's where alpha glucose inhibitors are not part of some of the international guidelines also. So now to the sulfonylurea, risk of hypoglycemia, weight gain, increased severe risk, yes, we know about it. So to the GLP-1, if we see the disturbances along with possibly associated with acute pancreatitis. Now focusing into the postprandial hyperglycemia management, we have the limited choice to act on as well as to look for what had been to the part of the talk is ripaglinide. So ripaglinide, action is glucose dependent, elicit insulin release in rapid and brief, taken with meals for postprandial hyperglycemia, reduce risk of long acting hypoglycemia, and improve beta cell function in patients with type 2 diabetes, restore early phase of insulin secretion, improve postprandial glycemia and reduces lipolysis. That's why postprandial glycemia management is important. Efficacy of ripaglinide is similar to sulfonylurea and has better potency than the nataglinide, and above that recommended by various reputed global societies as well as guidelines and clinical associations in postprandial hyperglycemia management, and specifically focusing on diabetes with kidney diseases. Now ripaglinide is a short-acting insulin secretagogue used for the reduction in postprandial, favorable safety profile with low risk of hypoglycemia, high potency, elicited insulin release is more rapid and brief, and as well as can be used for or alone with the combination. So why it is so different than the sulfonylurea? If you see, sulfonylurea binds to SUR1 on pancreatic beta cells and escalates the effect of insulin release from the pancreatic beta cells, where ripaglinides directly act to the different receptor where SU binds, and that is ATP sensitive potassium channel, and that's where it helps the glucose dependent insulin release and helps reducing postprandial plasma glucose as well as blood glucose. Now if we see at a glance, then insulinotropic effect, then the better insulinotropic effect than the glibenclamide or glimepiride, more rapid onset of action, and greater stimulation of insulin release and reduction in blood glucose level than the sulfonylureas available. An effect where glucose dependent with increased insulin level bind a transient effect, whereas reduced blood glucose persistently for up to 24 hours. So glucose and dose dependent insulin tropic effects are the one of the background for repaglinide. Now looking to the pharmacokinetics, it's absorbed through GI tract. Half-life is 1 hour, absolutely bioavailability of 56%, and distributed through protein binding and binding to human albumin greater than 98%. Metabolized through biotransformations, oxidative biotransformations, as well as eliminated through feces, and limited part through urine. So that's where the half-life is contributed. Now to the safety aspects. When we see the postprandial hyperglycemia management contributed by glinides, as well as metformins, as well as the gliptins. And this Danish registry showed that repaglinide associated with lower carbohydrate risk than the other insulin secretagogues. That's what CV safety available data with this mass of subjects. When we saw about the tolerability, then repaglinide and sulfonylurea agents tolerability almost similar, and that's where it has better effect. Now what we talked about is not only repaglinide alone, but repaglinide along with the combination or the usage of DPP4 inhibitor, where repaglinide reduces HbA1c more efficiently than sulfonylurea in combination with DPP4 inhibitor and causes fewer hypoglycemic events. Same way, another part of extension of this is showing the same effect on the reduction of postprandial hyperglycemia along with the decrease in the incidence of hypoglycemia in such individuals. Now recommendation for repaglinide in CKD. So what are the guidelines says? ACE guidelines. Repaglinide can be used safely in patients with severe renal impairment. Spanish Society of Nephrology. No contraindication for mild or moderate kidney failures. Reduced postprandial glucose level. Canadian Healthcare Society can be used in CKD. No dose adjustment. Also preferred in peritoneal dialysis populations as well. Swiss Medical Weekly can use in the dialysis individuals, and what Japan says is no dose adjustment. In even use can be taken to CKD stage 3 and 4 of the kidney transplant individuals also. So where is repaglinide place in therapy? If we see the managing hyperglycemia in patient with type 2 diabetes during early stages of disease has a more marked impact on CV outcomes, as it is a legacy time involved in those individuals, and that's where repaglinide restores the first phase of insulin secretion and potential add-on drugs after metformin monotherapy. It can be used in combination in early phase, but that is also a question how we want to act on the patient's postprandial glucose or his lifestyle. The proportion of the patient with primary diabetic nephropathy as well as comorbid diabetes. So if we see the chronic kidney diseases or kidney involvement, the repaglinide is the choice of drug in CKD patients. Even if we see the repaglinide choice of drug in CV risk individuals where the kidney also is part of it. So CVD along with anti-hyperglycemic agents to choose for, the cardiovascular safety profile is suggesting that can be used in a line. So in short, what repaglinide can be pushed in our prescription is when we have choice in early individuals with having postprandial hyperglycemia, newly diagnosed individuals where that could be rapid acting insulin secretagogues required, lower postprandial glucose excretion by targeting early phase of insulin resistance is required, effective glycemic control and well tolerance to the individual is required, effective in treatment with drug naive or add-on therapies to the OADs in type 2 diabetes individuals, including early elderly patients and those with the renal impairments. So flexible dosing related to meal times, 1 meal, 1 dose, extra meal, extra dose, and no meal, no dose. That's what the flexibility adds by repaglinide. I really thank everyone, and it is indeed pleasure to address you all, and pleasure that I made it into timeline and gave the buffer to all of us around.
Any question from you? My question.
Please.
In place of acarbose, the repaglinide is tends to cause hypoglycemia and weight gain. Very special place.
Very special space to use repaglinide above alpha glucose inhibitors.
Second CKD and that we can say.
That's a major indication, because in CKD patients where we have the electrolyte imbalance as well as the fluid restriction to take place where sometime alpha glucose inhibitors causing the GI disturbances, and that's where we put repaglinide ahead of alpha glucose inhibitor to some extent. Above that, if we see the young drug naive individuals or maybe elder individuals with add-on to metformin therapy, where we have a concern that they might end up to hyponatremia or hypernatremia or maybe possibility of dehydration, where also we can place the repaglinide in a lower dosage than the sulfonylurea or other drugs to add on to. Gliptins, yes, we have a choice to add on to above metformin, and with metformin and gliptin, if we want to choose any related to meal focus, then repaglinide. Above that, in Indian scenario as well as globally, when there are fastings are involved, where we put repaglinide to the further level. So Ramadan is around, Navratras around, and where people like to fast for, that's one of the choice to add on to. Yeah, that could be, but where we need to see what are the insulin resistance we are encountering to that individual, and continuous monitoring we can add on to, and what at present steroids are required, whether it is for COPD for longer duration or whether it is for any acute conditions where the steroids are put forward. That's where we need to look and place it for. Pleasure. Thank you everyone. Yeah.
Moving forward, I would like to invite Dr. Parikshit Goswami for the next lecture. Dr. Parikshit Goswami is MD TFID from CMC Vellore. He is a postgraduate diploma in endocrine South Wales and postgraduate diploma in diabetes mellitus from USA. He will be talking on 25 years of acarbose.
So before thanking RSSDI, my talk is very well in line with Dr. Yash talked. Targeting the yeah, that's what I'm. So I request Dr. Yash to stay here. So we'll have a debate as Dr. Sandeep Desai told.
I would not say anything is debatable. I will say everything is edible.
Of course.
That would be commanded.
That's wonderful. That's really wonderful. That's awesome. So at the outset, I am thankful to Team RSSDI, Sandeep Bhai, Pratap Jethwani Sahib, Dr. Bansi Sabu sir, and many others in the team for giving me to speak on acarbose. And this is a 25 years of using acarbose in the practice. And to my mind, the word 25 years itself gives a lot of confidence. How confident we are using these molecules since last 2.5 decades. So this is just an approval story of acarbose, and to my mind, the most important approval to use acarbose in type 1 diabetes. So this is the single most drugs which you can use in a type 1 diabetes, not a one postprandial reducing drug, that is repaglinide. We are talking too much about impaired glucose tolerance or the pre-diabetes patient populations, and where we do not have too much to do except diet and lifestyle modification. But in 2006, acarbose is approved for impaired glucose tolerance. So what is the idea behind the glucoside inhibitors? So the point here is that we are very much, when we say we are, I am talking about the Indian patient population. We all are high carb eaters, and it is very difficult for us, even us, to make changes in our nutritional behavior. And at the same time, to understand a diet is a very complex issue. And that all leads to unsatisfactory long-term diabetes control. But if we manipulate somehow the absorption part of the foods, which majority of contains a carbohydrate, then I think so we can target a lot of postprandial hyperglycemia very well. And why so? Alpha glucoside inhibitor has a place in our treatment armamentarium. Look at the normal absorption of a carbohydrate. Pointer is not working anyway. It's fine, yeah. Thank you, Sandeep bhai, sir. So look at the absorption of carbohydrates without acarbose, duodenum to jejunum. So if you add acarbose in this situation, then the absorption happen up to the ileum, and that's the crux of using acarbose in our patients. So acarbose inhibition leads to delays in intestinal carbohydrate absorption, lower post-meal hyperglycemia, and of course less insulin needed. What Dr. Yash told a few minutes back, the first phase of insulin secretion is hampered in type 2 diabetes, and I think so using ripaglinide is already hampered. You are pumping out the insulin, but not in case of acarbose once you use it. So thereby it improves the insulin sensitivity, and we are in the incretin era, and if this carbohydrate absorption happen over a period of time, then it automatically promotes the GLP-1 release. That's the crux. So whenever we eat and we know the how incretin works in our body. This is a comparison between three available alpha glucoside inhibitors available, like acarbose, voglibose and miglitol. So I'm not going to the scientific details, but the point here to note is that the alpha glucoside inhibitions has to be in a typical order, and that is exactly done by the acarbose. Glucosamine is more, then the sucrase, then the maltase, then the isomaltase and the determinase. And not much of a great extent of action is delivered by the voglibose and the miglitol. And it has a structural uniqueness that allows polysaccharide to enter the large intestine. And how it is important to save our beta cell by sparing them to not pumping out with the secretagogues. And once you reduce those postprandial peak without taking out any insulin from the pancreas, it's already there. If you do that, then you are saving the beta cell, you are saving the pancreas. We have a 25 years of a clinical evidence. If you carefully look the efficacy part of all the anti-diabetic drugs currently available, they all in a tune of 0.7% to 1.2%, except insulin, or at the most 1.4%. And acarbose also is in line with that. We are living in a combination era, and verified trial has proven that early combination therapy wins the race. And I will highlight how acarbose and metformin combination will be the best partner. And now we are looking a drug which should have a beyond the glycemic control. So I will highlight what GLP-1 response after using acarbose. And Dr. Yash told about the pentards and glycemic variability targets nowadays is most important, and how acarbose really target that issue. We'll lot talk about the gut microbiota and its effects on metabolism. And acarbose, this is a one single molecule which have effects on a gut microbiota. So that all need to understand. And again, what are the CV benefit with the acarbose? We have a recent trial. We have recent data, I would like to say, from the registry. So as I told, HbA1c reduction is not inferior to any current available anti-diabetic drug. So 0.8% in this placebo-controlled randomized trial, and this is a meta-analysis. So highest in the hierarchy, it shows efficacy part of acarbose. It not only reduces the postprandial hyperglycemia, but it also reduces, not greater extent, but it definitely reduces the fasting plasma glucose also. Again, this is systematic meta-analysis data of 46 study, and again, HbA1c reduction with acarbose is much greater with Eastern diet in comparison to Western diet. So this data again says that how acarbose is useful to our patient population. And again, Dr. Yash told that in the Western world, acarbose is not to be used because of social issues of farting, but in terms of efficacy, I would like to say we must use acarbose in our practice with this data set. And we have Indian real world evidence from GlucoVIP data. It is a multinational trial, but Indian patient populations were there. In 1996, it's not a year, but it's 1996 is exact number of the patients were enrolled in this real world evidence. And again, similar HbA1c reduction in line with the meta-analysis I showed. At 12.5x, the mean change of HbA1c was 1%. And 80% of the patient received less than 150 milligram per day acarbose. So again, you don't have to uptitrate it up to 50 milligram thrice daily in most cases, and what usually we do are in practice also. Acarbose compared with metformin as the initial therapy with the patient of newly diagnosed type 2 diabetes. This is an open label non-inferiority randomized trial. And again, it is in line with our expectation in terms of glycemic parameter reduction at 48 weeks time. So we all talk about adding acarbose to DP4 inhibitors and SGLT2 inhibitors, and this data shows how it have a similar efficacy in comparison to other OADs like DP4 inhibitors and SGLT2 inhibitors. STOP NIDM is one of the important trial for a pre-diabetes patient. We have a less number of the data set for pre-diabetes patient populations, and look at the reduction of incidence for the development of type 2 diabetes, that is in the tune of 25%. An increase in the reversion of normal glucose tolerance is 35% versus placebo where it is 31%. Acarbose, the best combination partner This is India phase study. Again, in similar line, over a 12 weeks period time, shows improvement in the fasting plasma, in the postprandial plasma glucose level and HbA1c in comparison to metformin alone. So we require a comparative study for voglibose and metformin and icarbose and metformin. And again, with respect to glycemic parameters, high reductions were reported with icarbose for HbA1c fasting and PP. So this is a meta-analysis for second-line anti-diabetic drug versus placebo in adults taking metformin. And again, in terms of efficacy part, icarbose is non-superior, I would like to say, with other class of anti-diabetic drug. But look at the hypoglycemia incidence, which is strongly, I would like to say, favored by this class of drugs, and particularly icarbose in this data. Again, in terms of efficacy, a comparative efficacy, icarbose is similar in line with other class of drugs when added to metformin. What are the other benefits beyond the diabetes control? For GLP-1 response, glycemic variability, gut microbiota, and CV benefit. So, as I earlier told, with icarbose, absorption happen up to the terminal ileum, and the amount of food, if it remains in the intestine for a longer period of time, then you will get the GLP-1 response. And that is what our analogs, GLP-1 analog does, that reduces the gastric motility. So the amount of food remains in the intestine for a pretty long time. So stimulation of GLP-1 typically happens after 60 minutes. And that is why we traditionally tell our patient to chew slowly, to eat slowly for 20 minutes, 25 minutes, 30 minutes, and eat protein earlier before the carbohydrate. Okay, so protein part is digested much longer time it takes to digest, and that is the crux, and that is why icarbose have a good role to play in our treatment armamentarium. And once you add the DP4 inhibitors along with the icarbose, that covers the whole story. Icarbose decreases intraday glycemic variability, and this data really reassure that how in comparison to Vilda and metformin and placebo group, once you add icarbose on top of the metformin and Vilda, how it reduces the MACE and standard deviation, the most two important glycemic parameters, glycemic variability parameters. Sorry, Chairperson, this talk is pretty long. Just give me 2 or 3 minutes more. Glycemic variability check with icarbose and premix insulin. So this is a difficult part in our setup. As a diabetes physician, as a diabetologist, we may encounter the patient who were already taking a premix insulin, and what we encounter is hypoglycemia. And I think so, once you add icarbose, and we all use icarbose or alpha glucoside inhibitor that matter in type 1 diabetes to reduce the insulin doses. Okay, because once you increase the insulin doses beyond certain units, for me it's 0.5 unit per kg per day, even in the premix cases, then you are giving a lot of hypoglycemia. That is a post-lunch and the post-dinner hypoglycemia, and adding icarbose on top of that with this open-label 12-week randomized trial, icarbose to insulin and metformin to insulin shows how the coefficient variation, MACE and standard deviation is markedly reduced in comparison to metformin and insulin group. What are the emerging evidence for gut microbiota as a treatment? again, this is a one of a kind, I would like to say, a randomized double-blind controlled crossover trial. Again, its hierarchy is much higher. It's a crossover trial. So higher abundance observed of a 5 genera, including Lactobacillus and Dilester. Alteration in a microbe at a genus level with acarbose, and this trial number is quite low. Number is 18. Again, it's a randomized control trial for type 2 diabetes patient who were given acarbose, and significantly higher abundance of Bifidobacterium, Eubacterium, Megasphaera, and Lactobacillus were observed. For the cardiovascular benefits, and this is a pretty long back study of A study, particularly in IGT, and they have included a 5 MACE component. It's not a 3 MACE component. Look at the cardiovascular rate, non-fatal myocardial infarction, non-fatal stroke, hospitalization for unstable angina, or hospitalization for heart failure. All were strongly favored by acarbose group. And again, this is a meta-analysis of 7 long-term studies which shows intervention with acarbose can prevent cardiovascular events in diabetes patient population. And this is very recent data, real-world data in 2018. What they have found, it's a pretty exclusive registry data, and which has shown a 33% relative risk reduction to hospitalization due to ischemic stroke, 31% relative risk reduction due to atherosclerotic events, and hospitalization due to myocardial infarction, 34%. If you compare this data with currently available SGLT2 inhibitors, I would like to say they are at par. And the one important take-home message for all of us that this data especially from in Asian patient population. So again, it's more of a important for all of us. This is again a Beijing community diabetes study, 10-year intervention, and again acarbose reduces the risk of myocardial infarction by 50% and all cause death by 52% at 10 years. And although we are a little bit fearful about the 4th wave of COVID, but any talk should not end without the COVID data. In this retrospective analysis of a cohort of 131 patients with type 2 diabetes hospitalized for COVID-19 in Wuhan, showed once you use metformin and acarbose, how it impacts the benefits, mortality benefits for COVID-19 patients. So, of course, Western guideline may not adhere, but our RSSDA ESI is always there. It's there in our guidelines, so you can use acarbose in your practice. So my take-home message for all of us is that any background therapy, I kept a BKIP, so I can give the take-home message without reading slides. So any background therapy you take, you can use the acarbose. You don't have to worry about that. HbA1c efficacy, glycemic variability efficacy, you can take. We don't have a cardiovascular outcome data, but this registry data really reassure that. And after using 25 years, you can really reassure that you don't have to worry about the cardiovascular inferiority or superiority for this molecule. It is very well established in our clinical practice. We all are dealing with the postprandial hyperglycemia because we love to eat more carbohydrates in our diet, and acarbose have a place. Why it is placed? You don't have to give a 150 milligram, a full dose, or even more, which is typically used in the randomized control trial data. Even a 50 milligram twice daily. But I request all of you to not to use once daily. At least use a 50 milligram or 20 milligram twice daily because of its mechanism of action. If you give it 3 times daily, that gives really wonderful. Many of my patients still are on icarbos and metformin combinations for a pretty long time. What about the durability aspects we are talking about for each and every drugs? You don't have to worry about the durability of aspects because it do not have any effects on the insulin to be secreted out. So, and we are living in an increasing era, and we have a cheaper molecule in comparison to current available GLP-1 analogs. So use icarbos freely in your practice. That is my take-home message for all of you. Thank you very much.
Thank you. Thank you, Doctor. Any questions on that? We'll move further.
Thank you, sir. Leadership presentation. Our next lecturer is Dr. Bharat Sabu, Chief Diabetologist and Director at Prayas Diabetes Center, Indore. Specially trained in data science for precision medicine from Edinburgh University. Various multiple national and international research publications and winners for multiple awards. But what is more exciting is working on develop to a AI-based model for precision healthcare delivery in diabetes, and is enrolled with IIT for course in artificial intelligence and machine learning.
Thank you.
Over to you, sir.
Thank you, Chairperson. Thank you, Gujarat RSSDI, for this wonderful event and the grand hospitality. So what I am going to talk about to you in next 15 minutes or so would look like a sci-fi movie like Avatar to you after all these acarbos and ripaglinide lectures. These two are wonderful molecules, but what I am talking to you are the molecules which most of them are not having names even at this point of time, but this is really interesting. So the flow would be the burden of the diabetes, which we all know we are dealing with, and that is what created the gap or the lacuna what we feel in our practice, and that's why we are interested into the future pipeline. We always look at the future pipeline when we talk about diabetes. And the conclusion. So we all know this slide is not new to us, and we know 10% is an understatement, 50% are not diagnosed, and blah, 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 and everything. And we know the number is increasing like anything. It will double every 10 years and all these things. But we have decoded this ominous octet thanks to Diffranzo. Diffranzo told us this. This is the pathophysiology by which diabetes occurs, and we are still not able to catch it in spite of having molecules which are dealing with all the octet parts. So all the 8 parts we have dealt with, but still we are dealing and having this menace of ongoing increasing burden of diabetes on us. So this is the list of US FDA approved drugs which we are using in day-to-day practice. Almost all of us are using these molecules, and in spite of this, 1 in 11 adult has diabetes, and by 2040 we will increase much further. It is the leading cause of death globally. The presence is across the globe, we all know, and it is going to increase, I would say, double every 10 years because we will be diagnosing more, so it would be an understatement to say less than that. Now this is the diabetes drug market which we are dealing with, and this market is growing like anything. But the bad thing about this being a market is again a burden on our pocket. So our healthcare is taking the money out of our pocket which we can use for other things, and this is paved really a way or the lookout for newer therapies. Is there any way we can tame out this burden of diabetes? So this is the way the global diabetes treatment market is expected to account for XXX amount of US dollars. So can anyone guess? This is about to reach 78 billion by 2026. So that is a huge number. We can use this amount for any development project, but we are unfortunately not able to tame this demon. So what are the future potential and what are the interventions we can have? We have the present therapies. You can see from alpha glucosidase inhibitor, just Dr. Parikshit told about us. Then we have GLP-1 based therapies, DPP-4 inhibitors, sulfonylureas. We are covering every organ of our body which we can use to cover for diabetes, but still we are not able to control. And that's why we have future possible therapies. For diet, we need something better than acarbose. We need prebiotic and food supplements, or if possible, directly the gut microbiomes which we can inject. SGLT1 has come up in the pipeline. Then satiety inducing agent which can reduce adiposity, which are analogs of GLP-1, not directly the GLP-1s, PYY and oxytomodulin. And there are then incretin mimetics also, and then small molecular receptor agonist. All these things are there on which work is going on since long. Then we have insulinotropic agent, tissue selective smart insulin is also there, which is coming up, which will act on its own. And it being an insulin will never cause hypo. This is a wonderful revelation to me when I was searching the slide for this. Then we have glucagon receptor antagonist, direct inhibitor of hepatic glucose production, which is again coming in pipeline. Then we have adipokine analogs or agonists or inhibitors. We have then novel insulin delivery routes via oral, buccal, skin, and whatever route it is possible. You tell any name and everyone is working on that. And then there are novel SGLT2 inhibitors which have more potent glycosyuric effect, so that we can yield more out of that 1% HbA1c reduction what we get out of the current SGLT2 inhibitor. We are acting on other parts also, like liver. We have these molecules which are acting on liver, on pancreas, directly acting molecule like amylin receptor agonist, glucokinase activator, glimulins, GLP-1 analogs. Then there are molecules which are acting on multiple tissues like direct AMPK activators, PTB1B inhibitors. Then there is a novel molecule which is GDF15 agonist which act directly on the central nervous system. And then there are FGF21 analogs to act on the adipose tissue. And again we have SGLT inhibitor, SGLT1 inhibitor which will work for us. Amylin receptor agonist, glucokinase, GLP-1, GPR119 and SGLT. I will take few of those because the time is very limited to me and I would like to finish in time. So this is my pick actually, which I have picked: activin receptor, activin type 2 receptor modulators, amylin or dual amylin calcitonin receptor agonist. So these are being developed by Key Biosciences. They are working on it, and Novartis. So FGF21 analogs are there, which is again in pipeline with Novo Nordisk. Then Teijin Pharma Limited is also there, which is working on a glucokinase activator. Then GLP-1 receptor agonist, which is there with various pharmaceutical companies, GLP-1 with GIP receptor agonist and GLP-1 with glucagon receptor agonist. Then we have GLP-1, glucagon and GIP, all three combined together working on the diabetes, which is being developed by Novo Nordisk and Hanmi Pharmaceuticals. Then we have GPR119, lin kinase activator, PTB1B inhibitor and SGLT inhibitor. The list is endless. It seems really like an Avatar movie to us at this point of time. But I tell you, when I was studying, DPP4 inhibitor was written in a very small line in font size of 6, I think, in the KD Tripathi book. So the DPP4 inhibitor now today has taken everyone by a storm, and these molecules, no wonder, can take everyone by storm any day. So I will start one by one. We have then activin type 2 receptor modulator, which is in the name of bimagrumab. This is a human monoclonal antibody. A phase 2 trial is going on, studying its effect on body weight and HbA1c, especially in overweight and obese patient, because we are already burdened with obesity now. So a lot of work is going on this, and it results in an increase in muscle volume, which is very surprising, and it decreases the fat tissue. So it in turn increases the insulin sensitivity and lowers HbA1c levels. It is a promising molecule. Then we have this amylin or duoramylin calcitonin receptor agonist, which is having a code name of KBP042 and KBP089. So KBP042 is in phase 2. It reduces glucagon secretion, it induces satiety, it delays gastric emptying, and it improves the glycemic control and weight loss. So all the therapies, most of them are focusing on weight loss also along with diabetes. So this has some core structure as calcitonin receptor. This is a new revelation, and it dual amylin calcitonin receptor agonist has been developed. So which binds to both the receptors. It causes a more potent activation of amylin receptor, and it is more effective in reduction in glucagon secretion and body weight. So they are working on the glucagon mechanism of sugar rise, and that's why they are very novel in their approach. Now then we heard about this molecule, direct AMPK activators, which is having a code name of PXL770, because we all know AMPK regulates the glucose and lipid homeostasis, body weight, food intake, insulin signaling and mitochondria biogenesis. So by inhibiting fatty acid synthesis and activating the glucose as well as lipid uptake and oxidation in many tissue, it will help in reducing the blood sugar burden. But very little information is revealed by the pharma company as such. Now we have fibroblast growth factor 21, FGF21, which is having a name of pegbelfermin. It is actually located in liver and adipose tissue. It lowers glucose and body weight due to activation of FGF21 receptors in the CNS. It acts on CNS, and these receptors are located in liver. So when we give this molecule, the mice increases fat utilization and energy expenditure. So fat is utilized for energy, body weight is reduced, fat mass is reduced, triglyceride comes down, insulin sensitivity improves. So this is mainly focused on NAFLD because we are still not able to curb this demon of NAFLD also, which is associated so closely with diabetes. Then fructose 1,6 bisphosphonate inhibitor. We remember our biochemistry days when we used to hear this molecule. Now it has currently passed 6 phase 1 trial and 1 phase 2 trial. Final results are to be published, but it inhibits the rate controlling enzyme fructose 1,6 bisphosphonate, thereby lowering the fasting glycemia. And it is independent of insulin level and body weight. But data is yet to be revealed. Then imeglimin. It is a OAD of the class glimins. It has multifactorial mechanism. It's suggested to lower glucose by increasing insulin secretion, enhance mitochondrial bioenergetics, increases muscle glucose uptake, and decreases hepatic glucose production. So this is again a novel molecule which is having a class of its own, and lot of molecules are being developed in this line of glimins. Then FFAR1 receptor, which are fatty acid receptor, GPR40. This augment the insulin secretion via an increased incretin effect. Again, the same incretin effect is coming here by a direct effect on the beta cell and a strong satiety effect. When it acts on pancreatic alpha cell, it reduces the glucagon secretion also. So one of this molecule, Facilgla-Farm, was discontinued due to hepatic side effect, just like we see with various DPP4 inhibitors also, although at the mild level. But the other brother is well tolerated without the risk of hypoglycemia, and trials are still going on, and this is again a very promising molecule which is coming up. Then we have the glucokinase activator. We have heard about these things. These are dorzagliatin and novel hepatoselective GKA-TTP399. These are superior to previous glucokinase activators because the work is going on for glucokinase activators since past 15-20 years, because it increases the insulin secretion and glycogen synthesis and reduces the hepatic glucose output. So long-term safety and efficacy data are still being evaluated, but this is again a very promising class of drug. Now there are mono, dual and triple agonists, as I have told you, with GLP-1 receptor agonist moiety, and the phase 1 and 2 study are going on for this under various code names, and we are yet to see the early data for it. Then we have glucagon receptor antagonist coming out in various code names, but they are all working for the same thing of reduction of HbA1c without reducing the body weight. Now then there are lin kinase activator. This is a new thing which is actually gaining various places in the scientific forums. This is tolimidone, and it is developed originally for gastric ulcers, but then was repurposed after patent expiry, and it showed that 4-week therapy improves the postprandial blood glucose levels and lipid parameters, but it doesn't impact HbA1c. Then there are protein tyrosine phosphatase 1b inhibitors. It is an intracellular protein tyrosine phosphatase which is involved in regulation of insulin and leptin signaling system. Again, the leptin and ghrelin are coming into play, but it is interesting to look for this molecule also after seeing the results of semaglutide, especially oral. Then sodium glucose cotransporter inhibitor. It is coming under various code names. SGLT1 will facilitate glucose uptake in the small intestine, like the brother SGLT2, which helps the reabsorption of glucose in the proximal renal tubules. So it decreases glucose absorption. So you see a replacement for acarbose if it comes there. Then tissue selective and smart insulin. This is very new thing and novel thing. They are known as smart insulin because they can be used via different routes. They are actually very smart, and they will release in order of the blood sugar values of the patient. So they will very rarely cause hypo, and they will have a very effective profile as well. So these are coming up. Now then there are various vitamins and minerals on which the work is going on. Whether they impact the glucose milieu of the body or not, we are yet to see. Then there are microbiome modulators, as I have told you, prebiotic and probiotic supplements, because they alter the gut microbiome and the formation of bioactive products like short chain fatty acids, and these are being fecally transplanted. The work is going on to how to fecally transplant them directly to the large gut so that we can reap out the benefit. Now these were the therapies for type 2 diabetes. Now coming to type 1 diabetes, there is a lot of work which is again going on, because we are also overburdened by the type 1 menace. And these are all the things which are going on to take care of our type 1 patients. These are non-insulin agents for prevention and management of type 1 diabetes. We are working on T and B cells. We are working on islet and beta cell specific approaches, including the islet antigen tolerization or immunization, beta cell stress relief, and SGLT2 inhibition has been postulated to be used in type 1 diabetes, and also the GLP-1. Let us see what comes out with the guidelines. Now, this is a very, very recent paper which is very recently published, and it shows the advances in pancreatic islet transplantation sites for treatment of diabetes. This is regarding the type 1 diabetes. What is done? A donor beta cell is injected into the host portal vein. This is a very novel technique, and the work has been going on since past 7 or 8 years. And what has come out? In the recent ADA, this gentleman, James Markman, presented this data, and this is a revealing data. Only 2 patients were involved, 1 male, 1 female, and both participants had improved outcomes, with one able to discontinue insulin after 200 days. The insulin was discontinued. It's an islet-based therapy. The cells are delivered to liver via the hepatic portal vein, as I have told you. The cells are allogenic. The only disadvantage is they will require immunosuppression. But see, the TIR from 40 rose to 99.1. The insulin requirement dropped to 0. So this is a revelation. This is a wonderful thing which has come up in the recent ADA. It was presented. Another thing which has come up in the conference just after the ADA, the Endocrine Conference, Society Conference, the ENDO, on June 11, 2022. They showed a stem cell based therapy which shows promise in treating high risk type 1 diabetes. What they shown? A PEC direct device. This is a simple patch sort of device which is consisting of stem cells. It is injected beneath your skin. It is having a pouch. It takes the blood supply from your blood vessels. By taking that blood supply, it gets nourishment, and in turn what it delivers the insulin. So this study involves 10 adults with type 1 diabetes. The initial data was very, very promising. The C-peptide levels were increased, decrease in HbA1c by as much as 1.5%, and the decrease in required amount of insulin by 70%. So 70% reduction in the required insulin amount. So this is again a wonderful novel tool which has startled everyone in this ENDO conference. And if you see, these are 3 types of patches which are developed, just for your understanding. The PEC direct, which I have talked about. Then there is a PEC NCAP, for which no immunosuppression is required because the blood vessel is not going into the pouch. And then there is PEC QT, which is again having cells which don't require any immunosuppression. So only PEC direct requires immunosuppression, and by the grace of God, if we are able to get the same amount of result from this PEC NCAP or PEC QT, the life of our type 1 diabetic patients will change forever. So these were some novel therapies. Researchers are already speculating about the microchips which will diagnose type 1 before occurring, nanorobots which will be inside our bloodstream, and they will measure glucose and they will deliver insulin at our will with the click of our smartphone. Then there are silica particles which will slow down the digestion of food. All this is there, but the time is limited. So the conclusion is a lot has been done, but we need to do a lot. A lot of promising technologies are coming for type 2 diabetes, which will change definitely the way we practice actually. After 10 years, we will be standing and sitting here again, and we will be talking about some novel molecule and new thing. Stem cell and islet-based therapies are to be looked up. In 5 to 10 years, they can all together change the game of type 1 diabetes. And whatever the future will bring, it will undoubtedly will make a huge difference in the lives of millions of people. With that, I thank you all with this quote. Thank you. Thank you.
Truly Avatar movie and with happy ending. Any question from audience?
Small comment.
Sure, sir, please.
Absolutely brilliant coverage of the things to come. Very exciting future you have outlined for all of us, and you have rekindled our hope for a better cure of all types of diabetes. And as I correctly recollect, if at all I am correctly recollecting, there was one class which is insulin independent out of the newer classes you described. So that will be another, perhaps a very exciting addition to SGLT2 inhibitors.
Sir, actually, the thing is, we need to think beyond insulin in terms of type 2 diabetes. This is my take. This is my personal take. We are so much engrossed with the insulin thing. I don't say insulin is bad, but type 2 diabetes is a metabolic disorder, first of all. we need to think about insulin sensitivity first. Then we need to think about insulin depletion. And then we'll thirdly need to think about insulin replenishment. If we are replenishing insulin without improving the sensitivity, it will never help our patient. This you all must have seen in your day-to-day practice. So the essence, as you have seen, the most of the therapies lie with reducing the fat, the visceral fat, which is the culprit, the weight, which is the second culprit, and third, the tongue or the mouth by which we eat is the third culprit. So most of the therapies are centered around reducing the satiety, decreasing the fat, and by any point of time, if we are able to get out of our smartphones and we are able to walk, we can look forward to a better future.
Excellent talk, I wanted to ask something about hemoglobin and all the claiming. So how they are working and how exactly their primary data coming up?
Primary data not has been revealed officially by actually the. Can you just put my slide once? Primary data, Rutul, has not been revealed officially by any of the companies. So actually, unless I get an official from their website, I can't put it on the forum. But the initial data is very, very promising. And actually, I just show you. This because works on everything. What you talk about, it works on. So it works on most of the factors of the ominous octet. So everyone is looking at this molecule, even the industry is looking at this, because this one molecule can give you what our 3 molecules give us. But this is very early data, and actually it is nothing has been official. So unless it comes, it is bad to comment. But I tell you, 5 to 6 years down the line, you and me will be talking on this only. Yes.
PGIP combination, this is the future.
And this is oral actually. And you are very right, this is oral. So this is oral being, actually India being a prick phobic country. So oral means always better. So everyone is looking at it. Let's see, we hope it comes and it will do wonders. Let's see.
Enhancing mitochondrial bioenergetics.
Yes, that is the most promising thing, sir, actually. That is the most promising thing. Because that is the root defect actually, and it is killing out the root defect which is there.
Do we end this session?
Thank you.
Please wait. Dr. Manish sir will give moment to Dr. Akash Singh sir. Dr. Parikshit Goswami.
Dr. Yash Patel to the honor, please.
Yes. Bharat sir, please.
I request Dr. I request Dr. Vinod Abhichandani sir to recite our chairpersons.
चलो भाई ओरिजिनल देवता
So we are quickly moving to our second session. For that, I request Dr. Nihar Kedia from the Surendranagar and Dr. P.D. Premjani from the Nadiyat. Sorry. Sorry. I request Dr. Lata Jetwani from Rajkot and Dr. Chirag Gandhi from Navsari to take over for the next session.
Good morning, everybody. We are thankful to the organizers for making us chairpersons of this session. And with that, we start our session. The first talk is on PVD in diabetes, underdiagnosed but potentially fatal complication. Dr. Ishwar, welcome, sir.
Yeah, it is indeed an honor and privilege to introduce Dr. T.K.M. Ishwar, my senior as well as mentor. He passed his MD Medicine from Diabetica College, Ahmedabad, 1989. At present, he is a consultant director at Ideas Diabetes Center, Rajkot. Multiple international and national publications to his credit, and has been a speaker, has been a familiar face actually, a speaker at various national meets, Athicon, RSSDI, DFSI, and Diabetes India. Over to you, Dr. Ishwar.
Thank you, Chirag, for the kind introduction. I would like to thank the organizers, RSSDI Gujarat chapter, for giving me a chance to come and talk on this topic. And it's a very important topic, I think, because though we know that as compared to Western countries, the incidence of PVD is much less in Indian people, I do agree that it's underdiagnosed and it leads to a lot of morbidity and mortality. So we need to understand why PVD occurs in diabetes, and basically there are three components. There is insulin resistance, there is chronic hyperglycemia, and there are free fatty acids. We know that the chronic hyperglycemia leads to production of advanced glycation end products. There is reactive oxygen production, activation of protein kinase, and then in the presence of dyslipidemia and hypertension, which are usually there in diabetic patients, there is inflammation, vasoconstriction, problem with the clotting, thrombotic abnormalities, the arteries become stiff, there is endothelial dysfunction, microvascular dysfunction, and it leads to lower extremity peripheral arterial disease. So these are all the sites where PVD can occur, but basically what we see in diabetes is occurring in the lower limbs, especially in the infrapopliteal arteries, anterior tibial, posterior tibial, and peroneal arteries. It can rarely occur in other areas, but in diabetes, commonest site is in the lower limbs. So why is PVD potentially fatal and having a lot of morbidity and mortality? Because 1 in 3 people over the age of 50 is likely to develop PVD, even in the general population. But in diabetic population, the risk of PVD is more, and especially if there is peripheral neuropathy, then PVD is more likely to occur. And the problem is that if there is an amputation, then the 5-year survival rate goes down like anything. So this is one of the big problems which we see, and about half the patients with diabetic foot wound also have a peripheral vascular disease. So the stages are stage 1, where there are reduced pulses, where we should act, because unless we look at the feet, we won't be able to diagnose stage 1. So repeatedly in a lot of conferences, every time we say that just don't treat the sugar, you look at the patient also. So feet need to be examined at every visit, or at least once in 6 months. This is the stage 1 of reduced pulses, where we can pick up very early. Stage 2, the patient will come and tell us that, when I walk for a certain distance, I get pain. When I take rest, the pain goes away. There is the stage of intermittent claudication. Stage 3 is rest pain, and then stage 4, obviously there are ulcers, or there is a black area because of gangrene. So the problem is that the symptoms don't occur until 60% narrowing is there. So you need to look for the signs, you need to examine the patient and find out whether there could be an earlier stage where you can intervene and do something. And if there is pain or change in the appearance of the skin or change in sensation, these are all red flags or warning signs. Intermittent claudication, as I told you, is very important. Of course, you should rule out neurogenic claudication. It's you have to differentiate whether it's a vascular or a neurogenic claudication. And usually in the people who are having this peripheral vascular disease, unless it's an advanced stage, intermittent claudication, once they take rest, the pain goes away. So you can have stable and unstable presentation. In stable, as I told you, asymptomatic only, if you do a investigation or if you examine the patient, you will find out. then there is a classic intermittent claudication. There could be a possible intermittent claudication where you may have a neurogenic component or maybe vascular component you need to rule out. You have this patients having leg pain, but they are able to carry on walking after taking some rest. And then finally those who are having quite a bad ischemia but still not critical, where the leg pain is there even at exertion and at rest. Then these are the acute things where the ABI is less than 0.40. There is ischemic rest pain. You need to intervene immediately. There is a non-healing wound or ulcer, and there could be gangrene also. So there are two types of classification of peripheral arterial disease, which the foot surgeons or the people who are treating it use. There is the Rutherford stage and there is a Fontaine stage. And basically in the Rutherford it talks mild, moderate and severe, while in Fontaine it gives you exact idea of how many meters you can walk without or with claudication. Then there is a rest pain, and then there is tissue loss in the form of necrosis and gangrene. So the most important thing that we need to do in order to early, make an early diagnosis, to look and touch and feel the feet. If you do that in your patients at least once or twice in a year, you will not miss PVD in your patients. So you need to inspect the skin. The skin is shiny. There is loss of hair. If you elevate the foot, when you elevate the foot, there is a pallor, and when the foot goes down, there is a rubor. There could be wet gangrene, but more commonly you will find the classical dry gangrene, which looks like a tree which has lost, a tree which is going to die. Palpation is very important, and it's very simple, very easy to do. You look for the dorsalis pedis, posterior tibial arteries, and most of the time you will be able to find out that this person is having or very likely to be having peripheral vascular disease. This is a very, very good test which can easily be done by everybody in the clinic also. And I think if you are going to treat patients with type 2 diabetes, you should be doing this test, which is known as ABI. And this is the interpretation that if it is between 1 to 1.4, it's normal. And then as we go down the range up to 0.40, it goes down from borderline to mild to moderate to severely abnormal. As the person becomes very old and the vessels become thick and calcified, then you will have a very high ABI because the vessels are incompressible. The lower limb ABI we usually measure with a Doppler, while upper limb we can measure with a stethoscope. We can use the Doppler for both also. Another thing is that if you do the ABI properly, it's more sensitive than a TMT to diagnose even a cardiac this thing. So if you are having a positive ABI, then maybe these are the patients whom you can subject to further investigation to rule out a cardiac problem also. These are all the special tests which we can do: duplex Doppler, TCPO2, angiography, CT and MR angiography. But again, these are all, once we feel that there is a PVD, maybe we do ABI, maybe we can do a Doppler, then I think we should refer them to a proper center or a specialist who is doing this work so that they can be managed in a better way. So basic treatment strategy depends on whether they are symptomatic or asymptomatic. If they are asymptomatic, you just look at them, you find that the pulses are weak, you do an ABI, it's abnormal, it's not normal, but they don't have any symptoms. Or you have a person who has had a peripheral revascularization but is now asymptomatic, then the most important thing you need to do is to look for the MACE reduction. So this is very important, you should stress on it. Change in lifestyle, do more exercise, eat properly. Tobacco cessation is very, very important, and it should be asked and stressed upon every time. Statin therapy, of course, that has been discussed yesterday also, and blood pressure control, preferably with ACE or ARB. And we'll talk about antiplatelet therapy, in one of the slides further on, which antiplatelet to use in these people. If it is symptomatic, where the ABI is less than 0.85, or there are people who are having peripheral vascularization with symptoms, then it's a red sign and we need to do something about it. So of course all the previous things like lifestyle, tobacco, statin around will come, but we need to add a thiazide or pyridine, that is we use dipyridinol commonly, or we can use a PAR antagonist, I'll come to that. We want to reduce the limb vascular events, then statins and PAR1 antagonists are there. And then of course silastazole, exercise and statin therapy also may be used. So this PAR antagonists which are recently available, they are protease activated receptor 1 agonist and antagonists, and they are potent antiplatelet agents. And Voraxapar, which is available in the market, and etopaxar is still not available. So we need to, when we are looking at patients who are having peripheral arterial disease, we need to understand that if they're quite symptomatic and we feel that the limb is at risk, they should be on one of these drugs. Usually we use dipyridamole and maybe aspirin or something, or maybe celestazole, but in certain cases we need to think about this drug also. So if the patient is asymptomatic, then just look at the risk factors. If there is intermittent claudication, with the help of good exercise and risk factor management, if they are stable, then we just monitor them. But if there is a critical limb ischemia or intermittent claudication not improving with exercise and with the risk factor management, or if there is worsening of symptoms, then we should refer to the vascular surgeon. And those who are having a diabetic foot ulcer, if they are having PAD, 50% of PAD, so if you find it is there, then we should urgently refer them to a center where they can do a proper vascular assessment and management. So these are the vascularization strategies. There is an angioplasty with stenting. If there is a very thick calcium, then you need to do a rotational atherectomy, almost similar to what we do in the heart. And then of course we can use a bypass surgery endarterectomy either with the Dacron grafts or with a saphenous vein graft. We can bypass the affected area if we have got good vessels in the periphery. So these are all just some slides which I have taken. Very excellent article which came in NEGM about 3 years back. Bigger stents, with a wider bore, which are larger in size, little bit more expensive, but much easier to place as compared to the coronary arteries. So you can have a self-expanding stent, you can have a femoral endarterectomy, you can have a patch, you open the femoral artery, remove the clot, remove the not the clot but the thrombus or the obstruction, and then you close it with a patch, or you can have a femoral to popliteal bypass graft. And this is again the showing the angioplasty and the stent in position and how we can bypass. In the left side you can see with the saphenous vein they have bypassed the obstructed multiple segments which we see in diabetes. So you go past all the blockages, go to the distal part of the artery which is patent, and you are able to establish a good supply so that the limb can be saved. So if you want to choose between endovascular surgery or open bypass surgery, you have to look at so many things. So of course this is a subject for a vascular surgeon, but then since we are treating diabetes, we just need to know which are the, because many times patient will ask us, "Su karse humne operation karse ke su karse?" So we need to have an idea what is the thing that the doctor is going to suggest to them. So you have to look at the patient whether they are good candidate for a surgery, depending on the age, the comorbidity, the life expectancy, whether they can tolerate GA or not, whether you will be able to use a saphenous vein or not. Then you evaluate the foot, what is the type of lesion, what type of surgery you want to do. Then you have look at the vein, whether the veins are good, whether the veins are available. There is a good big segment of vein which we can use for the bypass. Then we look at the peripheral vessel, whether the diameter is good to have a bypass, whether it itself is not calcified, and all these things if you consider and they are all good, then you can go for an open bypass surgery. Otherwise then we should go for endovascular approach where we can go for an angioplasty and stenting. Again I talked about antithrombotic therapy, which is very important, and we should give patients who are having peripheral arterial disease antithrombotic therapy. If they are asymptomatic, we can consider aspirin, especially if some other vascular bed, if they are having coronary or if they are having erectile dysfunction or somewhere else, if you think that there is a other vascular bed which is involved, then we should give aspirin even to an asymptomatic patient. Symptomatic, all patients should be given aspirin or clopidogrel or aspirin with rivaroxaban. But if there is a recent history of a stent or acute coronary syndrome, then dual antiplatelet therapy. Again, you should look at the long-term risk, because especially in elderly people, if you give dual antiplatelet therapy, there could be a cerebral bleed. Then you should think about revascularization, whether it could be surgical or endovascular. If you are going to give endovascular procedure, then of course you have to give DAPT for 1 to 6 months. Thereafter aspirin with clopidogrel or aspirin with rivaroxaban. And if there is a high limb risk, then we should intensify the thrombotic therapy. You can give a oral anticoagulant, or I told you one of the PSPR1 antagonists also can be given. Always look at the ischemic risk, the bleeding risk and the limb risk whenever you suggest antithrombotic therapy in a patient with peripheral arterial disease. There are other novel and experimental therapies. Mesenchymal stem cells have been used. Maggots are approved by US FDA. Looks horrible, but then it cleans out the ulcer very well, promotes granulation. So this is an exotic therapy, but very much in this thing. Then you have this bioengineered blood vessels, where you these are donor cells are seeded onto the scaffold, and then the scaffold is placed in place where there is a this thing, and it automatically grows into a new vessel. So these are all this is article from 2020, so still in research. Of course, if you don't do anything, and poor patients many times they come auto amputation because there is gangrene, so the gangrenous part gets amputated automatically. So basically the thing is that we know that diabetes is associated with greater severity and more diffuse PAD. We know that usually when we do an angiography, we will get a triple vessel disease in diabetes. Unlike non-diabetics where you will get a single vessel, you can go for a stenting. In diabetes, you need to usually go for a bypass. So they will have more diffuse and more severe PAD. Of course, in India, it is much less than West, so we are very lucky. Because of this PAD, there is a greater mortality, especially if they undergo amputation. The impaired quality of life is also there. There are multiple mechanisms by which diabetes induces atherosclerosis, and so the plaques are there, and they are, they can either, you can have a full thrombosis, or the plaque can rupture and you can have a distal block. So whenever you have this, you need to look at the patient, inspect, palpate, do ABI, do a Doppler, and then send it to a team where there is a multidisciplinary approach, so that we can improve the clinical outcome in this population. Thank you.
Thank you, Dr. Ishwar. That was indeed an exhaustive and all-encompassing presentation covering all aspects of peripheral vascular disease. The forum is open for questions if somebody has any questions.
What is your experience with that drugs you told?
I have not yet used.
And second one question, do you have any experience using GLP-1R in peripheral vascular disease?
No. I don't even know about it.
Any data you?
No, I don't know anything about GLP-1R in peripheral vascular.
Okay, thank you.
One question from my side, sir. If 60% of the patients are going to be asymptomatic, then how do you decide which patients to screen and how to?
Simple, just inspect, palpate. If you find that the pulsation is weak, if you put your hand in both the dorsalis pedis and you find that one side, you are going to do ABI also. Ideally, when you are treating good number of diabetic patients, you should do ABI at least once in a year. If it's normal, maybe initially younger patients you can do in once in 2 years also, but you should do once in a year. And if ABI is abnormal, you should do a Doppler and you should investigate. If ABI is abnormal, you should also look for coronary artery disease, because it's a very, very strong marker for coronary artery disease. So I would suggest that each and every diabetologist, this is very simple, very easy, it's not at all costly, should invest in ABI and should look at the feet, touch and feel and look at the feet and see what is going on. So though they are asymptomatic, that is the place when we should detect. Once they become symptomatic, then there is semi-critical to critical limb ischemia. So if you detect when the block is less than 50%, then you are able to give a better result, because you are able to give antithrombotics, or you can give antiplatelet agents. You can improve the quality of life by stopping the smoking or the other tobacco and other things. Give statins so their plaque becomes stabilized, and you can improve the quality of life, and maybe they will go on for a longer time without any intervention being needed.
Thank you.
I request Dr. Chirag Gandhi to felicitate. Anybody to take the benches?
Yeah, they are there. Audience is taking that. Good enough. Thank you.
Thank you, sir. I request, don't be impatient. I request Dr. Gandhi to felicitate Dr. Parikshit.
Thank you. Thank you.
Thank you, Parikshit. You can sleep at peace. We welcome Dr. Abhichandani for his talk on hypoglycemia, a major challenge in diabetes mellitus management. He has done his MD and he has done his MSc in endocrinology, University of South Wales, UK. Sir is a lifelong learner, a lifelong teacher, and at his age, he is inspirational. He is working in the field of diabetes and endocrinology since Jan 1985 at Ahmedabad. He has been a principal investigator in several phase 3 trials. He is a member of the American Association and the European Society of Endocrinology. as well as EASD. He is a life member and an RSSDI fellow. He has been a guest speaker at various regional, national and international conferences. He is the regional faculty at Ahmedabad for CCEBDM, GDM, MH, ACMDC, CCDR and MDEP. So he is totally into teaching for his life.
Thank you very much, honorable chairpersons and all esteemed colleagues. I wish you all a very good morning.
Age is just a number for him.
But all these young colleagues of mine are perennial inspirations for me, let me tell you, all of you are. So, thank you very much, and I will, over next 15 minutes, try to, the first slide is the thing. Yeah. So, cover this topic, hypoglycemia, a major challenge in diabetes management. Hypoglycemia caused by treatment with a sulfonylurea or a glenide or insulin is the limiting factor in the glycemic management of diabetes. It causes recurrent morbidity in most people with type 1 and many with advanced type 2 and is sometimes fatal. It generally precludes the maintenance of euglycemia over a lifetime of diabetes, and in turn it impairs the physiological and behavioral defenses against subsequent hypoglycemia. And in 2013, this is a paper I quoted, it's co-authored by Honorable Dr. Sanjay Kalra, and he had given a very good breakup: below 70, mild hypoglycemia; below 55, moderate hypoglycemia; below 40 milligram, severe hypoglycemia. In 2017, the International Hypoglycemia Group gave a slightly different picture, and the third category, they did not ascribe any figure. Anything below 55 can be moderate or severe. Not included that. And autonomic symptoms resulting from hypoglycemia include trembling, palpitation, sweating, anxiety, hunger, nausea and tingling. And neuroglycopenic symptoms include difficulty in concentrating, confusion, weakness, drowsiness, vision changes, difficulty speaking, headache, dizziness and tiredness. I'm sorry I'm recapping something that all of you are masters of, but I thought for the sake of completion, let me do that. And what is the counter-regulatory response to hypoglycemia? So unfortunately the pointer is not working. We start at the top, sensor. So the brain has brain glucose sensing mechanism. They are located in the hypothalamus and brainstem. And once hypoglycemia occurs, sugars fall below 70. There is a autonomic nervous system activation at hypothalamus level, and norepinephrine and acetylcholine get secreted. So at the pancreas, you have the effector organ, pancreas and adrenal glands, and the counter-regulatory hormones, glucagon, insulin. There will be a switch off of insulin, which is the first response. And then there will be increase in glucagon, followed by increase in cortisol, and lastly, epinephrine. So at the liver, you will have great gluconeogenesis and glycogenolysis, so correcting the lowered sugar. And at the muscle and fat level, there will be decreased glucose utilization. So what is the putative mechanism of hypoglycemia unawareness? Recurrent hypoglycemia results in a reduced autonomic response to hypoglycemia with attenuation of autonomic warning symptoms. So on the bottom, the 5 symptoms which get attenuated are captured. So there is reduced, I think first I need to go and see here, no problem. And where my, excuse me, I need to put on my glass also. So there is reduced sweating, and then part of glucagon production under autoimmune control gets reduced, the second one. And at the third is the absence of palpitation, which patients would normally become aware of and run for some kind of correction. And there is reduced production of catecholamines and absence of tremors. Now, why does this occur? Because at the brain level, the maladaptive response in the brain is characterized by the increased GLUT1 activity in a bid to preserve brain function. At the top is the inscription. and alter glucose sensing in the ventromedial hypothalamus, that is VMH, mediated by elevated levels of GABA, which is gamma aminobutyric acid.
You can use the cursor as the pointer.
Okay. Yes, I think I'll do that. So here I present my first case. Perimenopausal 47-year-old lady arrives at her consultant's office for a routine examination. She visits Dr. Pariksit, who is one of the most competent young diabetologists we have in the country. Now this lady has height 160 centimeter, weight 80, gives her a BMI of 31.2. She has a family history of type 2 diabetes, heart disease and stroke. But so far, she never had diabetes. Now, our Dr. Pariksit is always keen to undiagnose or unearth undiagnosed cases. So, he subjects her to routine blood work, and she comes out with a HbA1c of 8, with a mean average glucose of 183 and a fasting blood glucose level of 173. Doctor orders a repeat test to confirm the diagnosis of type 2 diabetes. Patient is very reluctant, as all our patients are, to start medications, and asks her PCP to suggest any alternative therapies she could use instead. After a thorough explanation regarding the benefits of glycemic control in this lady's case, where she has strong family history and she herself has been hypertensive and dyslipidemic, ultimately Dr. Pariksit could convince her to agree to start taking metformin. And she is at the same time briefed properly regarding self-monitoring of blood glucose, medication management, exercise, blood glucose goals, behavior change, and culturally sensitive meal planning. On follow-up after 3 months, unfortunately her HbA1c remains at 7.7% with fasting blood sugar ranging between 170 to 200. Now, patient A is started on additional glipizide 10 milligram twice per day because of issues of economics. Both patient and her daughter have been briefed regarding the action of glipizide as well as the potential side effects and the importance of eating meals on a consistent schedule to prevent hypoglycemia. 1 month later, patient's daughter calls the primary care physician in our in a national case. I am again going to refer to Dr. Pariksit in the mid morning to report that her mother was working out in the yard and became dizzy, shaky, sweaty and confused. So, Dr. Pariksit immediately asked her to do a random sugar of her mother. The daughter is asked to do the patient's random blood sugar, and it comes to 45 milligram. Then she is instructed to offer the mother something sweet instantly, and the patient consumes 6 ounces of orange juice. The blood glucose is rechecked in 15 minutes and the result is good, 97 milligram per deciliter. And then she is obviously called to the clinic, where the certified diabetes educator who happens to be a part of Dr. Pariksit's team assesses the patient's medication understanding and adherence. So at this point, my humble question is, what else could be explored in this case? And I think the answers are also captured here. Timing of medication and meals we have to ascertain. Breakfast, the quantum of breakfast taken, blood glucose level prior to working in the yard, if at all it was recorded, and other episodes of hypoglycemia. We have to at times ask a leading question to get answers to such queries. And if there was a fasting blood glucose done on that day, that should have been inquired about. A recall of her breakfast reveals that this patient took 2 diet khakra, 200 ml of fat-free milk and a cup of tea. The educator also inquires about use of holistic or herbal remedies. In the morning, Dr. Om and some of us had this discussion that people innocuously divert to holistic or herbal remedies. And this lady also hesitantly confided that she has been consuming some Ayurvedic powder daily twice. And the CDE, that is Certified Diabetes Educator, informs patient about the potential interaction of many herbal medications and their possible adverse effects. And the importance is also briefed to invariably share this fact that she is taking something extra Ayurvedic preparation with all her
doctors wherever she goes. And her glipizide dose is then reduced to 5 milligram twice a day. She is been, it's recommended to her to maintain a week of multiple SMBG readings and share the same with the CDE a week later. And this is a diagram telling us how hypoglycemia can trigger a cardiovascular event. So it can do that by, it's not working, it's working, okay, causing inflammation, inducing endothelial dysfunction, which in turn will reduce vasodilatation, inducing some coagulation abnormalities, and resulting in sympathoadrenal response with increase in adrenaline, leading to rhythm abnormalities and sometimes tachyarrhythmias and unfortunately SCD, and some hemodynamic changes leading to increased contractility and heart workload. My next patient is a Gujarati boy, 16 years of age, with a 5-year history of type 1 diabetes. He is on MDI, glargine as a background basal insulin, and a rapid-acting insulin analog for meal and correction boluses. Patient B has experienced a roller coaster effect with his glucose levels, and he has difficulty in school recently due to fatigue and headaches. He has not been sleeping well at night and wakes up exhausted in the morning. And when asked to recall his blood glucose levels, he states his morning glucose levels have ranged between 189 and 215. And the treating doctor suspects as a result nocturnal hypoglycemia and possible Somogyi phenomenon. Now, as we can recapitulate, the patient has experienced headaches and fatigue, high blood glucose levels in the morning, and he is waking up exhausted, and these are all signs of nocturnal hypoglycemia. The physician instructs relatives to assess his blood glucose level at 3 a.m. to identify if Somogyi phenomenon is an issue. She also prescribes, it happens to be a lady competent physician, and she also prescribes the use of AGP, ambulatory glucose profiling, to identify glycemic variability. Now, with this advice, I intend to share 2 slides dedicated to TIR. So, time in range captures the highs, lows, and in range values that characterize daily life with diabetes. TIR offers a nuanced cause and effect understanding of diabetes. For instance, we can see how specific foods or exercise affect our TIR. And this is a nice diagram which gives us the story. 3 different patients, same HbA1c, same average glucose levels, but see the time in range spent by each one of them. One spends just 40%, the next patient 70%, and the third one 100%, which is the most ideal situation. So people living with diabetes experience different energy levels, moods, and overall quality of life when they are in range versus out of range. And time in range can capture these differences in a way that HbA1c cannot. And then there is a term flat narrow in range, and this is the ideal picture that everybody can dream of. People with type 1 or type 2 diabetes can strive for FNIR. So in summarizing my talk, hypoglycemia and diabetes is associated with increased morbidity and constitutes a barrier to glycemic control. Most self-monitoring diagnosis of episodes of symptomatic or asymptomatic hypoglycemia can be treated effectively by rapid-acting carbohydrate. Approximately 20 grams of glucose constitutes a reasonable dose in most cases, with an expectation of clinical improvement within 20 minutes. Effective patient education is essential for reducing the risk and consequences of hypoglycemia. Physician-patient collaboration is vital to develop and modify a treatment plan that is acceptable to the patient, and the use of newer anti-diabetic medications with little or no risk of hypoglycemia. So you are all aware of the 3 classes available: GLP-1 receptor agonists, SGLT2 inhibitors, and DPP-4 inhibitors, and for that matter even pioglitazone in select cases. So the risk of hypoglycemia is minimum with these agents, and if we adopt feasible technologies, this will all help in reducing the future risk of hypoglycemia. Thank you very much for your patient hearing, and if there are any questions, comments, criticism, everything is welcome. Yes.
Thank you, Dr. Abhichandani sir, for case-based, lucid and interesting presentation covering practically all aspects of hypoglycemia. The forum is open for questions.
Questions, criticism, and everything is good. Yeah. Yes, please.
Definitely we have now all the guidelines which are evolving, and constantly we are thinking of that, yes, we have to keep it less than 7, less than 6.5.
Yes.
And in such conditions, we are coming closer to hypoglycemia every day.
True.
We are seeing more and more patients. I guess earlier, when I remember I started practicing, it was around maybe 5-10%, or we were not asking such questions, and we are not aware of that self-monitoring is such a powerful
tool. Yeah.
And now it is, everything is changed. So we are seeing, I guess, a 25 to 30% of patients, or maybe more than that, of our patients having hypoglycemia. So what are your comments on that?
I agree with you, because with the advent of technology, the rate of detection of even mild, moderate or severe hypoglycemia have largely increased. So I think you are absolutely dot on spot when you say that you are seeing more cases of hypoglycemia. But having said that, you also simultaneously are enjoying armamentarium which will help you nip this problem in the bud. So if you, glipizide was just one of selection, because I wanted hypoglycemia to be. I am sure Dr. Pariksit would, is going to bash me outside of this hall. Okay, why did you quote my name? I never write glipizide in such a lady. So anyway, you are absolutely right. Any comment, Pariksit?
I completely agree with Dr. Rutul. So in my practice, if 10 new patients come to me, then in them, for 3, I have to treat for hypoglycemia, not for hyperglycemia. I need to correct hypoglycemia.
Yes.
And what is your take on if you face a patient with HbA1c 9% or 10%, even at that HbA1c level, with the highest possible glimepiride doses, what we see recently from another specialty, 2 days back even, glimepiride 4 milligram 3 times a day. So in such situation, what you will correct? Whether you will correct hypoglycemia or hyperglycemia?
I would obviously correct hypoglycemia. It will be simple to address by reducing the dose or removing the culprit, the iatrogenic source. I think it will be easy to tackle hypoglycemia, but at the same time, I would like to minimize the glycemic variability. So do a AGP in such patients, gradually withdraw, or even suddenly if you want to take a call and withdraw, which is I would personally not be keen on removing all 12 milligram of glimepiride, because he will have wide and escalation of his sugars if I do it suddenly. So I would reduce the dose and monitor him. If he is not affording, or if I can't manage for his AGP, I will request him to do multiple SMBG, and then probably give him a modified prescription which is hypoglycemia proof in a way. So you have all the agents and you are master of using this, metformin, SGLT2. If the patient needs DPP4 or a GLP1, you can combine these 3 and probably make sure. Yes. Yeah, hypoglycemia is addressed like this, and yes, insulin. I think he also just mentioned in the morning that early insulin initiation is the way to go forward. But having said that, you have now degludec, which is literally peakless. So you can initiate on degludec, switch to IDEC-S. So these are all options. But if I talk of oral or non-insulin therapies, I think we have now a large basket to choose from. So yes, insulin is also one way, but insulin not pre-mixes or maybe the older ones. We would go for the newer analogs which are proved to be peakless. Okay, thank you.
Sir.
Thank you, and thank you for your input. Thank you very much.
Yeah, Dr. Jetwani to offer a memento to Dr. Abhichandran. Thank you, Dr. Jetwani and Dr. Abhichandran. Now we move on to the next, the last
fellow in diabetes from Apollo Hospitals and Liverpool, UK, postgraduate in diabetes from Czech Republic, Greece, Middlesex, UK. So he's done his post-graduation from 3 places. Managing Director at Arogyam Healthcare, Multi-Speciality Hospital, NEHC Diacare Diabetes Center. His area of interest is type 1, type 2 and obesity. He is the Regional National Faculty for NDEP and conferences, and is involved with multiple research and clinical trials, a member of RSSDA.
It's enough, I guess. Thank you for the kind introduction, Dr. Lata ma'am and Dr. Gandhi. So thank you very much, RSSDI Gujarat chapter, Dr. Bansi Sabu sir, Sandeep Desai sir, Pratap Jetwani sir, and Urman Dhruv sir, for having me here and letting me talk on my core thing that I want always to be talked about. So management of pre-existing diabetes in pregnancy. So what are the pre-existing diabetes types? Any type of diabetes which is pre-existing, like type 1, type 2, LADA, maybe MODI. But the catch is even pre-diabetes, that is before pregnancy. If you screen and diagnose anyone in pre-diabetes stage, he is already hyperglycemia in pregnancy patient. So such patients are not being taken care properly in early stage and especially in first trimester. So take care whenever the patient has impaired hyperglycemia, please take care. So in every case, try to keep HbA1c less than 6.5 even before pregnancy. So pre-pregnancy counseling is very important, and we know that, but the problem we know, there is a twist. भूलती रह गए सर, गलती से हो गया. Already, I would say 30, 40 or 50% of our patients, when they are referred by gynecologist, obstetrician or IVF specialist, their HbA1c is maybe 8, 8.5, 9% sometimes. I have seen type 1 diabetic patient who has already HbA1c of 11%, and a gynecologist is sending the patient whether we should continue with the pregnancy or not. So this is very common condition. So try to tell your connected gynecologist, obstetrician and other IVF specialists that please try to pre-counsel before pregnancy that your HbA1c should be less than 6.5, at least less than 7%. So what are the targets? Targets, a baby should not realize that her mother has any sort of hyperglycemia. That should be target. So it should be like a non-diabetic mother has the sugar, it should be same to a diabetic mother. So targets are fasting blood sugar should be less than 90 and post-meal blood sugar should be less than 120. It is very stringent, we know. So this is the range, but I would say that fasting even we could keep between 70 to 90 and not 80 to 90. I have seen many of the patients who keep their fasting blood sugar around 75 or even 70 and they don't feel hypoglycemia. Post-meal blood sugar can be between 100 to 120. Mean plasma glucose should be between 95 to 105. In a normal pregnancy or non-diabetic mother, their fasting blood sugar is between 71, that is plus or minus 8. So it may be around 63 to 90, not more than that in non-diabetic pregnant lady. And what about post-meal? Post-meal 1 hour is less than 122 always, and post-meal 2 hours is less than 110. So this is why those targets are kept so low. So try to keep what a non-diabetic mother's sugar readings are in a diabetic mother. So this is the example of one of my patient, which is actually a pre-existing diabetes. I have written diagnosis, my staff has written it wrong, but it is pre-existing diabetes, IVF and GDM at 17 weeks. we can see that this is how we can follow up. Every second or third day they have to check their blood sugar. Ideally, I ask every day to check 3 to 4 times, but this patient, after controlling blood sugar, we have asked her to check her blood sugar every third to fourth day, and this is how we can keep fasting. You can see it is almost less than 95. A post meal blood sugar is almost less than 120. You can see that. So and we can follow up and we can ask them, and we can use the technology EHR for our own better outcomes. AGP, although it is not approved, that is Freestyle Libre Pro, but we can use it as educational tool, and I already presented a abstract or a paper in DIPSI last year, and it was showing that by educating them that your fasting blood sugar is little on higher side, so you can change your diet, or you can change your diet in the evening. This is what we can explain. And it also shows estimated HbA1c, though it is not useful in pregnancy. And if we are using Freestyle Libre Pro, we are treating those patients retrospectively. So it is not advisable, but yes, you can use it for patient education. So ultimately what it shows that yes, your time in target or time in range should be more than 70%, and we should try to keep it between 63 to 140. This is the recommendation. But now Freestyle Libre, which is approved, which is a real-time blood glucose continuous glucose monitoring system, and it can be used. So I'll move on to treatment. If we come to management part, definitely MNT is first part that we should use aggressively in all diabetic patients, especially in our gestational or pre-gestational diabetic patient. This guideline is for a gestational diabetic patient, but this can be applied in pre-gestational or pre-existing diabetes patients as well. So MNT, we can give the time for 2 weeks maximum and not more than that. And if it is not controlled, if it is less than 120, then we can continue the same treatment with MNT or metformin or insulin, whatever is going on. But if it is more than or equal to 120, then we have to initiate metformin, or if patient is not on insulin, not on basal insulin, then we can add according to blood sugar data or the self-monitoring data. So what MNT says, this is very busy slide, and we usually get bored by these numbers, that how much calorie they should take, but it is in sedentary work, it should be 1900 plus 350 during pregnancy, so it is 2250. Moderate, then 2580. Heavy work, then 3200. But in further addition or deduction of 500 calories per day is recommended as per following table, and you can I will share if anyone wants. So hypocaloric diet in obese women with GDM can adversely impair fetal growth beside ketonemia and ketonuria. So in obese women, you should not go for very low calorie diet or low calorie diet. You should be really thinking on it. But moderate calorie restriction, it is around 30% of estimated energy needs in obese women with GDM may improve glycemic control without ketonemia and reduce maternal weight gain. So now we'll move on to main important part of pre-existing diabetes, that is treatment. Which OHAs are approved? Though glibenclamide has data in many parts of the Western world, but definitely according to DCGI or our guidelines, they do not recommend glibenclamide. Metformin, yes, but there are some problems when we can use, that we will discuss later. But we should know that every OHA crosses placenta, and that should be kept in mind. And because of that, in MIGHTY trial, it has shown that higher population of small for gestational age in infants. So the patients who are given metformin for treating gestational diabetes, their baby have small for gestational age, and this is the problem we are coming up with. Though we have seen that yes, definitely insulin doses are reduced, adiposity is reduced in maternal as well as fetal adiposity. Also there is a reduced maternal weight gain, and definitely blood glucose control is better if you are giving metformin along with insulin or alone. Metformin exposed children were larger at 9 years. This was the MIG tofu trial. This was the follow-up study of MIG, and what it showed that if you give metformin to a mother, gestational diabetes or pre-existing diabetes mother, after 9 years of follow-up, what they have found that baby has high weight, or they have increased body weight and adiposity. This is the problem. So during pregnancy they have reduced weight, but after a few years, after a certain age, they are gaining the weight in the patients who are getting metformin. Their children are increasing the weight. So this is the problem. So metformin or insulin therapy is accepted, but what is the catch? That insulin is the first drug of choice, and metformin can be considered, but after 20 weeks. Yes, in pre-existing diabetes, if patient is already taking metformin, then you may continue in obese patient, in PCOS, history patient or certain patients, but you should not initiate before 20 weeks. This is what we need to understand. This is clear guidelines from DIPSI and our national government guidelines as well. So insulin can be started at any time during pregnancy for GDM management. If pregnant women with GDM before 20 weeks and MNT failed, then insulin should be started. So before 20 weeks, you should initiate with insulin. But if after 20 weeks, you may initiate metformin alone along with MNT. So a drug of choice is insulin always. So which kind of insulin? You may use premix insulin, but yes, you should ideally use basal bolus therapy. Especially, I would say, I have used analogs in very large number in most of my patients, and they have tremendous result. As human regular insulin, they have peak. Like if we use NPH, which is approved, definitely many of the elderly doctors in our group, they are using NPH, and we have seen that it has peak. We have to give it twice. Human regular insulin, if we give, then we have to give ideally prior 30 minutes before each meal, and which is quite a big problem. So ideally you should use basal bolus therapy along with analogs. So which are the analogs? Except human regular insulin, Fiasp is the choice now because it is ultra fast acting insulin, and this is why we should use, though you can use Aspart, Lispro, and glulysin has no data in pregnancy, so we should even not continue glulysin if even in type 1 diabetic or pre-existing any other condition of diabetes, then glulysin should not be continued as we have the option. But for basal insulin, there is a different catch. So advantages of Fiasp, it is its action begins faster, peak is higher, and disappears also faster. Aspart also reduces major total or nocturnal hypoglycemia, and also same story with Lispro. But what about basal insulin? If we see the fasting blood glucose, when the fasting blood glucose is high in pre-existing diabetes, then we should initiate with basal insulin. Definitely this is the common thing. Detemir, if we see, it is the first choice in pregnant ladies in any kind of pre-existing or GDM. What about Glargine, Degludec, Glargine U300? There are few articles. We know that the Glargine, for Glargine we have the clear statement that if physician think that in pre-existing diabetes his blood glucose is very well controlled, and if they stop Glargine, your blood glucose control may not be as good as with Glargine, then it is physician's call. and it is completely physician's decision. If they want to continue, they can continue Glargine 100. What about Degludec? We have some data for Degludec even in type 1 diabetic patients, pre-existing diabetes. So pregnancy outcome in women with type 1 diabetes using insulin Degludec, and that was for 90 patients, and it was prospective study. So this suggests that Degludec, this is the conclusion of the study, that this suggests that the Degludec initiated before pregnancy can be continued throughout gestation. That was the conclusion. And the another trial was EXPECT trial that evaluated efficacy and safety of Degludec versus insulin detemir in pregnant women with type 1 diabetes. Insulin Degludec was found to be non-inferior to insulin detemir with respect to HbA1c prior to delivery, and also comparable for safety profile. So that was the head-to-head trial between Degludec and detemir, and it was found to be safe in type 1 diabetic patients. So we can use it in type 2. I am not recommending that you should use it, but we have some data, so you may continue in pre-existing diabetic patient. And what about Glargine U300? I would say I have the largest number of patients on Glargine U300 pre-existing diabetes, and soon I am going to present it in IDF mostly. So around 135 patients were used. They were initiated. They were not initiated. They were already on Glargine U300, and we continued it, and it showed safety was not an issue. So with this, I'll conclude, and if we have any question, query, anything or comment, it is welcome, please. Yes.
Thank you, Dr. Gopalan, for an elaborate and exhaustive presentation on a tricky subject. Yeah, questions, please.
Already Dr. Rapolo can speak everything detail. Suppose somebody is on type 2 diabetes, if they are on Glargine 100 or if they are Glargine 300, then what are you going to do actually in your clinical physical practice? Somebody is on Glargine 100 or Glargine 300, and if now they are going to become pregnant, so what are you going to change? Are you going to change the insulin before the conceive? Sometimes a lot of the time we have observed we are going to get a reference from our gynec colleagues, and most of the time pregnancy was basically unplanned. Then how are you going to dealing basically in your clinical practice?
Yes, the important thing is what is glycemic control. First of all, if it is not good control, you may change insulin. You may start with detemir, which is the gold standard basal insulin for pregnancy in diabetes. But yes, if you think that yes, Glargine would work and their glycemic control is good, HbA1c is in good control, then you may continue. There is now the clear guidelines, and there is no kind of a level recommendation, which was earlier like it was a level C or something, Glargine was, but now they have removed this classification. So you may continue. I am telling that I have used Glargine U300 in large number, and I have not found any kind of safety concern.
But then the problem is now sometimes we know that it is safe.
Yeah.
But the challenge is medico-legal issues in this.
Yeah.
Because what happens is that let's say something goes wrong, right, which is entirely not our fault. It is most likely some other affair, right? The problem is that then it becomes a little if you have some data, some publication, some somebody recommending it, then it's probably good. Otherwise, the challenge is that if something goes wrong, then we are in trouble. As long as things are fine, because we all know. See, end of the day, now all insulins are really
Almost
safe,
safe.
right? I mean, that is in fact much safer compared to any other agent that we use.
True.
Right? And end of the day, it's just the depot which is there, and ultimately it's just the monomer which is going into the system.
True.
So technically, it's the same insulin which is there in
And
circulation.
that we
So
can't
it's a
explain in medico-legal case.
medico-legal issue.
So
that's a
my
problem.
answer for this thing is that for Glargine U100, if you see, our national guidelines as well as DIPSI, they tell that in pre-existing diabetes, if it should be physician's call. So we are the physicians, and for Degludec we can show the data. Like we have some data for Glargine U300. If I publish it, you can use my data. So this is what we can do.
The basic.
Seriously, because I mean, see, nothing happens.
Yeah.
And generally, it doesn't happen.
Yeah.
Right. Nothing. But pregnancy is a tricky thing.
Yeah. very true.
If there is,
Very true.
see,
But
more
this
than
is
a
all about
gynecologist.
confidence of our gynecologist and the patient who are referred. That are,
Basically, counseling is very important.
yes, yes.
And,
So usually I write it on my prescription that
before
you,
I am an OBGYN.
yes, ma'am. I
So,
will know.
so seeing everything and seeing the current situation, what I think is that once any lady is coming to me now, I get her sugars done. I never used to get them done previously, but now even when she is non-pregnant and she is coming, she is newly married, she is coming for something, I always get her sugars done, get her thyroid done, and I always advise her periconceptional folic acid and B12 because these three are the most important things. And the basic problem is hyperglycemia. The problem is not the drugs. Hyperglycemia is the major problem. So if she has pre-existing, see GDM, the patient's baby is not going to have any anomaly because of diabetes. But if she is having pre-existing diabetes, then that first trimester hyperglycemia would be the cause of concern. And I mean, if the first time the patient comes to us, we do their sugars. So you should always, tell your gynec this, that get the sugars also. Because now what everybody is getting is, they get their thyroids done, but they don't get their sugars done. Sugar comes, OGTT at 13 weeks, at 24 weeks, like that. So awareness is the only key of the doctors and the patients. Once the patient has diabetes and uncontrolled sugars, the chances of anomalies are twofold.
So, yes.
Absolutely, madam, we are agree with you. See, in our area, basically, I am practicing in Ahmedabad, and we have made some basically strategy with our close referring gynec doctor. We have just started the basically preconception basically counseling and clinic, and certain reports like hemogram, thyroid, lipid profile, A1C, that has to be done whenever patient is going to come any gynecologist.
HB electrophoresis should
be also be. They are doing basically, madam, their part we are going to take care. But for metabolic disease, because most of the time now the female are going to plan to conceive after 30 years, and they having underlying lot of pre-existing disease, and we never come to know suddenly after 3 months, 4 months, and they give they went for the infertility. Actually, the pre-concept counseling should be required, and we have made a protocol. I think in 1,000 rupees there are the basic lifestyle disease we can screen out, and then we can go ahead. If there is any problem, then they can refer us, and we are just trying to treat disease, and ultimately patient is going to get a better outcome.
True.
And this is a major issue that you highlighted. A very important common challenge that we face is ladies conceiving after 30, 35, close to 40, where gynecologists will also struggle to ensure good outcome. So it's a very good strategy. Congratulations.
We can't help that actually. Dr. V. Sheshai, we met him last time, and what he said was that you just give one message to the ladies that get pregnant early, so that you will not have any complications. But people are not willing to get pregnant. What we can do?
Career is more important.
They are just not able to understand what problems they are going to face later on.
Thank you.
Thank you. With that, we come to the end of this particular session 6A.
I request Dr. Gandhi to give a message. It was quite interesting. Thank you, everybody.
Thank you, ma'am. Thank you, sir, for chairing the session. I request Dr. Sandeep Desai, sir, to felicitate our chairpersons. After this wonderful session, we have the debate over here, and for that I request Dr. Vidyut Shah from Rajkot and Dr. Rohan Patel from Bharuch to chair the session. Welcome, sir.
very interesting session coming up, and that is the debate. And the debaters are both the titans. One is Dr. Om Lakhani from Ahmedabad, and I will not go into the detailed introduction, but he is a winner of many medals, and he is a renowned endocrinologist from Ahmedabad. I think at the same time, the second debater is the Dr. Pradeep Joshi from Bhavnagar, and he is also a keen debater, and they are going to speak on what should be the first line therapy, whether metformin or SGLT2 inhibitor. And I think we'll give 10 minutes to both the debaters, and in the end they will have 1 minute for rebuttal.
Sure.
Okay.
Thank you.
Please.
Thank you for the kind introduction, sir. And thank you to the organizers for having me today. So the debate today is what is the ideal first line therapy in patients with type 2 diabetes, whether it's metformin or SGLT2 inhibitor. Now, currently the evidence is, all guidelines support the use of metformin, but now with ESC 2019 had suggested that, perhaps SGLT2 inhibitor could be considered as a potential, competitor or potential first line therapy as well in patients with type 2 diabetes. Okay, so first of all, before we begin, I think it's very important to disclose my side of the argument, right? I've been asked to speak on the topic in favor of metformin, but I personally believe that in today's world, and this is my philosophy for diabetes management per se, I don't think that either of them are relevant first line therapies for type 2 diabetes. I think we are in an era where we have to consider early intensive glycemic control. Gone are the days when the patient comes with diabetes and we start with metformin, and then after a few months we start with SGLT2, and after a few months we add sulfonylurea. That treatment is gone, right? I mean, the treat to fail approach that, start a drug, if it fails add a second, if it fails add a third, that approach has to go. I think the approach has to be that you start the patient on early intensive therapy, and then you de-escalate therapy. And in that case, I think in a patient who comes, let's say with young patient comes without comorbidities, comes with HbA1c of 7.1, 7.2, I think in such a patient, an ideal drug to start would be a DPP4 metformin combination. Safe drug, long-term effectiveness, and now with verified trial, you have some data to suggest that it is the best therapy. So that's my philosophy, and I think that's the message I would like to really give. But let me still defend metformin, because right now guidelines continue to defend metformin as the first line therapy in patients with type 2 diabetes. And why this is so and why this should continue is what I would like to really debate. So the first argument is very clear. In the earlier talk as well, see, whenever you have something which is recommended by guidelines, it is a very safe approach, because whenever you prescribe anything, we are in the world of medical legal issue, not only even medical legal issues, end of the day, there are many issues which arise, there is evolving patient mistrust and so on and so forth, right? So it's always better to stay close to guidelines as possible. The closer we are to guidelines, the better it is, in terms of, when somebody else sees a prescription also, it's always good that you are doing a rational kind of treatment, right? So if you see the ADA 2022 treatment recommendation, it very clearly says that first line therapy, of course, it should depend on a lot of other things, and generally includes metformin. So the point is that, whether you add something or not, and, as a add-on therapy, metformin should be there in your treatment as first line therapy, right? So it's like saying that breakfast ma tame biju kai khao ke na khao, cha to tame piwana cho, right? It's like that. It's essential, it's irreplaceable in terms of treatment, right? And the reason is very clear why guidelines continue to support is that, over a long period of time, we have seen a lot of safety with metformin. We have seen that it's a very effective drug. We have seen a lot of pleiotropic benefits. And most importantly, for a country like India, it is very cost effective, right? You have, metformin available across the country, even in the smallest of center, even the most remote center, you will have some form of metformin available at a very, very reasonable and cheap price. Again, RSSDI guideline, right? Right now we are in middle of an RSSDI conference, and I think we stick to RSSDI guideline, right? So RSSDI guideline suggests that metformin should be initiated often in combination with lifestyle interventions at the time of diagnosis. So even RSSDI guidelines, and this is the most recent one, suggests that the first line therapy should be metformin. So as of now, there are no concrete diabetes guideline. The ESC guideline was a cardiology guideline. That's the only one. Right now, all diabetes guidelines, including IDF and AAC and everyone, recommends metformin therapy. So that's the first thing. The second argument, and I'm sure my competitor would say that there is cardiovascular safety or cardiovascular benefit of SGLT2 inhibitor. So at this point of time, right, whenever you want to say that I want to use, let's say I want to use glargine instead of detimir in patients with pregnancy, I should have an RCT to prove, right? RCT solves everything. Right now, there is absolutely, and I don't think there will be one in future, there is no RCT which compares metformin versus SGLT2 as first line therapy, right? There is no drug, no head-to-head comparison as first line therapy. On the other hand, there is a trial which compares metformin with metformin plus vildagliptin, which is verified trial. It's an RCT which has shown that metformin with vildagliptin is better. But similarly, there is no trial which compares metformin and SGLT2 as first line therapy, right? I don't think there will be one, but if there is, that will conclude the matter. But as of now, we don't have a clear-cut RCT. And once you don't have a clear-cut RCT, replacing a standard of care from a guideline is not possible, right? So it is okay at a personal level we may treat patient, but in a guideline level or at a national level, at a RSSDI level or international level, we cannot suggest that. Third argument, of course, is that, like I said, a lot of SGLT2 trials, you have noise level generated from SGLT2. All remember that all SGLT2 trials, most of the patients were already on metformin. So in reality, the evidence we get from SGLT2 trials are not about SGLT2, they are of SGLT2 plus metformin combination, right? That is the broad point, right? There were very few patients who were not on metformin and on SGLT2. For example, if you say, I'm not showing all the trials in interest of time, if you just take the EMPA-REC trial, and if you see all the categories here, patients on placebo, EMPA-10, EMPA-25, etc., 75% of the patient were on metformin, right? So they were already on metformin. So whatever evidence you get, is it evidence for SGLT2 alone? Is it evidence for metformin alone? Or is it evidence for combination of the therapy, right? End of the day, empagliflozin 10 milligrams, 75% were also on metformin, right? So end of the day, the point is that the clinical trial evidence, all this glorified evidence of SGLT2 inhibitor is about SGLT2 plus metformin. Please remember this. In majority patients, right? We have small subset of patients where SGLT2 alone has been seen, but again, like I said, there is no head-to-head comparison of SGLT2 alone and metformin alone that we don't have. Then, of course, again, when you talk about first-line therapy, guideline, change, all that, we are talking about a more universal thing. Let's say if I put something in the guideline, there are certain organizations which have to strictly follow guidelines. For example, certain government or institutions, certain clinical trials, right? So in that scenario, what happens is, let's say, we know that every patient under the sun is not a candidate for SGLT2 inhibitor. We know that, right? All patients it's not indicated, it is not tolerated, there are a lot of problems. So SGLT2 inhibitors requires a more thought before writing a prescription. Unlike metformin, probably metformin you can give to anybody, including pregnant women. You can give it to pregnant women, you can give it to pubertal children, you can give it to adults, elderly, certain levels of CKD, up till EGFR of 30. You can give it to patients with chronic liver disease early on before they become decompensated. So lot of broad variety of patients you can give metformin. You cannot give SGLT2 to every single patient. You have to be selective. Which patient you can give, so it's overall, SGLT2, you have to be very selective. And again, a lot of people listening to this, I would always tell you that be selective. Otherwise, that's a problem, because a lot of patients, have problems with SGLT2, which they come back with. So that's the fourth argument. The fifth argument is the discontinuation rate with SGLT2. So recently in the ADA, there was a very interesting talk on precision medicine, where they took a lot of data. So what they did, they took a data of a lot of their patients on follow-up, and then they put the data in an algorithm. They use machine learning, and they wanted to see that what candidates of patient, what patients would you give SGLT to, what patient will give metformin, what patient will give combination, what patient will give DPP4. So they did all this analysis, and they wanted to kind of develop an algorithm for precision medicine. And then they did a prospective study. So they identified clusters that this patient we should give SGLT to. So they gave this patient SGLT to and prospectively followed up. Now, very interestingly, they got a large number of patients where SGLT2 should have been their ideal drug, right? But very interestingly, and they published this, right? Though SGLT2, lot of patients were in candidates for it, and the precision medicine algorithm showed that SGLT2 should be a drug, the discontinuation rate was highest amongst SGLT2 group. That's the problem, right? That's the reality. I mean, we all sit in our ivory towers and think, but at the end of the day, when the patient is taking the medicine, if the patient discontinues the medicine, he gets no benefit, right? So that's a lot of problems, especially Indian patients. Lot of Indian patients do not tolerate SGLT2 inhibitor. Let me tell you, I see every day, I'll tell you one patient who comes with, we had Dr. Abhichandani sir talk about hypoglycemia, patients coming with hypoglycemia, a lot of patients, coming in hospital. I have every day one patient who comes with some problem associated with SGLT2. Their diabetes is well controlled. They'll say, Maru sugar saru che, control ma che, but aa dawa man nathi fauti, right? So I want to change this. So they come for a second opinion or whatever, right? So there are patients who a lot of patients do not tolerate SGLT2 inhibitor, and discontinuation rate, especially in Indian patients, is very high. I am all for, it's a very good molecule. I'm not saying anything against the molecule, but the point is that you have to be selective. That's the key message. Finally, of course, the sixth argument is evidence of absence does not mean absence of evidence, right? We all have been saying SGLT2 inhibitor has cardiovascular benefit, GLP has cardiovascular benefit. Do we know that metformin doesn't have cardiovascular benefit, right? In fact, on the contrary, I'll tell you, UKPDS trial, if you go back, the original mother of all trials, they had a subset of patients who were only on metformin, large number, subset but still large number, and they compared metformin with sulfonylurea, which were used during that time, and they found that patients on metformin had weight loss, had better glycemic control over a long time, and had cardiovascular benefit, right? Even on the follow-up study. So end of the day, there is small, and that is the reason why metformin got a prominence in terms of first-line therapy for type 2 diabetes after this UKPDS subset. And in that context, right, that was never followed up. There is no dedicated CVOT trial for metformin. Perhaps it is done. Maybe metformin is as good as SGLT2 inhibitor in terms of cardiovascular benefit. We don't know, right? Because we don't have a trial. And absence of evidence does not mean evidence of absence, right? Doesn't mean that metformin doesn't have cardiovascular benefit. Maybe it has, maybe it does not, right? At end of the day, it's difficult to say. What we do know is that SGLT2 with metformin or GLP with metformin has cardiovascular benefit. That I know, right? So that's the key point, right? So it's difficult to say that, so end of the day, perhaps metformin may have good cardiovascular benefit. It's difficult to say, right? So I'll just summarize, anyways, I'm end of time, run out of my time. Yeah, so I'll just summarize, last slide. Take home message, just one take home message, right? SGLT2 is not for everyone. See, that's the point, right? It's a great drug, fantastic drug, good drug. When you're talking about as a first line therapy, it's not for everyone, right? You have to be selective in prescribing the molecule. And let me tell you, I'm not trying to be, dejecting the molecule again. I'm just telling you the reality of the situation. If you use SGLT2 as first line in every single patient of ours, please be prepared to lose your patients, because there are a lot of patients who will not tolerate it, who love the physician so much that they can't go back to them and say that, sir, I don't want to take this. They'll probably go for a second opinion or third opinion or whatever, right? That's the problem. A lot of these patients, then are lost. So that's the challenge, right? So yes, excellent molecule. Yes, I think probably either of them should not be first line. I would say probably DPP4 with metformin should be first line. But the reality is that at this point of time, there is no reason to, remove metformin from its throne. Thank you.
So after listening the excellent talk for the metformin part, now I would request Dr. Pradeep Joshi sir. Sir is a MD Medicine. He did it from BJ Medical. He has also served as a AP in Medicine and Medical College Bhavnagar. Sir has been ex-president IMA Bhavnagar and delivered many state and national level conference. So over to you, sir, to hear about the Rafale after the Mumbai has addressed about the MiG-29.
Thank you. I follow his YouTube videos and Facebook posts. Actually, thank you, the organizers, for inviting us. As Om said, metformin is the gold ring, and gold without diamond just doesn't look good. So we are entering, and this metformin contains the letter M, and there are some followers who always say that M doesn't have any option. We know who second M is. So I will be very quick because most of the slides will be repeated of. This is not moving actually. Hello. Slides are not moving. Okay, so Om said that SGLT2 is not tolerated by the patient. Let me tell you, the metformin is also having some GI intolerance, and that is not uncommon. That is also very common. So we are always fearing why to start at 1 gram or 1.5 gram. Sometimes fussy patient who always comes to you with gas. So we are preoccupied that this patient might not tolerate 250 also. And I always used to tell that he or she is the most unlucky person who is not tolerating the metformin. So metformin is a gold standard. But now Advani is out and Modi is in, so something has to be same in medicine also. So somebody say that why early? Why you are giving SGLT2 inhibitors early? Because the patient is coming late. You see, the 50% of the patients either have macrovascular disease, microvascular disease, retinopathy, etc. when they are entering in your office. So it is early for you, but it is already late for the patient, and the train has already been missed. The Indian patients have high incidence and prevalence of the diabetes, high prevalence of coronary artery disease, undiagnosed disease, and unaffording of the care. The OM didn't mention that SGLT2 inhibitors are costly because the generic medicines are now in the market. So we have multiple problems. Now the SGLT2 inhibitor, when it came into the market, I remember my words of my PG teacher, Chirag Vainabi PG teacher, okay, this is just excreting the glucose. What wonder it is going to make? All were having that impression. So for a few months nobody was enthusiastic, and then the trial started. Let me tell you, Om, the cardiologist and nephrologist are the ones who always try to omit the metformin. कि भाई CCF हो गया, अभी lactic acidosis हो गया, stop. But they are in love. They have fallen in love, and they are writing outright whether the patient is diabetic, whether they are going to convert the patient diabetic into diabetes by giving loads of rosuvastatin. They are first SGLT2 de do bhai, patient will be fine. So there are multiple problems in the diabetes, and why this molecule is making wonder, because it is throwing out the sugar outside, but it is also causing the remodeling in the heart. It is also causing the nephroprotection. It is also increasing the eGFR in the patients who are already having nephropathy. Now this is not seen with any other molecule. This is achieving a very good weight loss, which is almost impossible with most of the therapies of the diabetes. In some of the studies, the metformin has been mentioned as weight neutral. They are still not mentioning that it is causing the weight loss. And you all will agree that this is the molecule. The patient looks like, घना patient એવું કહે કે હું સાહેબ મેરેજના રિસેપ્શન જેવો લાગવા માંડ્યો. So this is a molecule which can achieve that thing. So weight loss. Yesterday, a non-alcoholic fatty liver disease, a drug, SGLT2 inhibitor, was mentioned that it can also reverse the non-alcoholic fatty liver disease just because of this weight loss. So I call it a poor man's metabolic surgery. This patient is not going to the metabolic surgeon, but he is achieving the weight loss. Same slide which the OM showed, but I want to put the 3 markers there, the red markers. The SGLT2 inhibitors are mentioned in the guidelines of the ADA. So SGLT new first line treatment, 9.4A metformin, but 9.4B if the patient is having atherosclerotic cardiovascular disease, high risk patient, then you can use SGLT2 inhibitors as a first line therapy. Again, just like he's told, metformin is a gold, put a diamond on that ring and give the combination, that will give you the best result. If you see the nice guidelines, the SGLT2 inhibitors are used even when the patient has no risk, if the patient has atherosclerotic cardiovascular disease established or at risk of that, you have to use the SGLT2 inhibitors. So these are the red marks where the nice guidelines have shown. The OM mentioned the 2019 European Society of Cardiology guidelines. These cardiologists and nephrologists are in love of these SGLT2 inhibitors. So they have used in a patient who have established cardiovascular disease with metformin or without metformin, also as a monotherapy. But when the patient is already on the metformin, adding the SGLT2 inhibitors has the benefited to the patient. I will not go into the detail, but whenever the patient is at high risk, if the patient is at low risk, okay, you can give the metformin. But if the patient is at very high risk of atherosclerotic cardiovascular disease, the SGLT2 inhibitors are always good option. CKD, underutilization of SGLT2 inhibitors in CKD. This is a USA data, and still because of the old age, just before few days I met one senior physician. He said that I am afraid of the severe urinary tract infection. So still people are afraid. The inertia from the clinicians is the main factor that we are underutilizing this drug. Now the DAPA CKD preventing renal failure, if you see the incidence of worsened chronic kidney disease, there is 39% reduction, number needs to treat is 19. So this is a very significant. The KDIGO guidelines 2020, if the patient is having established, the chronic kidney disease, diet and exercise are always the first, which our patients never follow. Second comes the metformin SGLT2 inhibitors, both are like twin brothers. If your GFR is below 45, apply the brake. If it is below 30, you remove these molecules. But if the patient is tolerating these two molecules, then these are going to give the best results in the kidney patient, because they apply the brake on the progression of the end-stage renal disease. He already mentioned this EMPIRIC outcome. It has shown that all major end-stage mortality, CV death, all-cause mortality, hospitalization, new or worsening of the nephropathy, progression to macroalbuminuria, doubling of the serum creatine, everything has been reduced significantly when you add SGLT2 inhibitors to a metformin. So past 2 years, all these studies and the generic dapagliflozin, that is a boon for us. This is just like a HOPE study. The HOPE study showed that there is something Ramipril is offering which is beyond the hypertension control. So same thing you can tell about the SGLT2 inhibitors, that they are offering us something extra, and we Indians love this bonus. LIC ने बाद का बोनस मिलने के लिए अभी हम जूझते रहते हैं यार, कि लाइफ के बाद भी मिलेगा. Then this is something which a bonus is giving by a molecule. The evidence continues. We have the DAPA and metformin also now in generic market, and the trials are coming out again and again showing more and more results. So this is a very large study, Darwin, 281,000 patients, and HbA1c reduction was 0.7%, body weight 2.7 kg, that is a significant weight loss, and systolic BP, this is a effect of a diabetic product, which is perhaps not by any other product, where a reduction of the blood pressure is also seen. So glycemic control, weight loss, renal improvement, and lipid improvement. These are the 4 things which can be achieved by, I will not use the word monotherapy because I am also against, but when you add it to a metformin, this is the benefit you can get. Heart failure, we all know the cardiologists are low. 5-4-3 approach, 5 pathways, angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT. And the molecules we have are angiotensin receptor blockers or ACE inhibitors, beta blockers, the spironolactone, and the SGLT2 inhibitors. So SGLT2 inhibitors is now the drug which is used to treat the patients with heart failure. Early cardiovascular benefits, you see the graphs are separating very early. So you get the early benefits, so start early, that is the only message I want to give. Just one study from the India, when the clinicians were asked why you are not giving SGLT2 inhibitors to the patient, the major cause was the cost, and now this cost factor is addressed. So we can use it very, very effectively to these patients. Many things we can use, new diagnosed uncontrolled in addition to insulin. I tell you, just frankly tell me, you all must have a patient like Chaganbhai Maganbhai who are coming to you 70 units of insulin, 80 units of insulin, keeping sugar around 300. Which molecule you added and he went into the hypoglycemia for the first time? That is the SGLT2 inhibitor. So it will reduce your insulin dose and patient will be better controlled. So these are all the patients. In this, the nephrologists and cardiologists are using even in non-diabetic patients. So summary, for decades good glycemic control was the only way to reduce severe renal risk, and SGLT2 inhibitors is just like icing on the cake of a metformin. Thank you.
Great job. Now I will ask Dr. Lakhani to rebut.
No, so I'll first revert by saying I completely agree with everything sir said. So that is the thing. And in fact, I once listened to sir talk about fever in one very interesting talk, and I still remember I was a MD student that time, and I still remember that. And thank you. So the only point here is that like I said, I completely agree with a lot of the things he said. The challenge, however, is to consider as a first line therapy as monotherapy before metformin. Now, I'm sure he'll agree. In fact, I also see a cardiologist sends a reference to me for seeing a patient with diabetes in the CCU post CABG. He's already started the patient on empagliflozin. So I think before the monotherapy with SGLT2 has already started. But having said that, I think all patients unfortunately are not candidates. So when with more people being using this molecule, will probably identify a good subset where you should use and should not use. But universally, if we start prescribing, a lot of the times, a lot of patients would end of the day discontinue. It's not just UTI. I didn't talk about UTI because I don't think that should be a deterrent. It's very less. The frequency is less. But again, if you use it more frequently in all patients, sometimes there will be patients who might be, at risk of developing UTI, complicated UTI. So end of the day, I agree with what sir said. I know it's a great molecule, but I think it's too early right now to say that it's a first line therapy in preference to metformin as a monotherapy. I think you need to have an RCT comparing both of them head to head. Only then we can say for sure. But till then, I said metformin should be first line. Then perhaps, the second therapy, either on the same day you can add, or you can add it after a few months, or you can add it whatever. But then it's okay to add a second drug, either DPP4 or SGLT2 or whatever you would like. But I think metformin should be part of the treatment. That should be.
Yoshi.
100% agreed. Diamond cannot be weird alone. There has to be a golden base. So there is no role of SGLT2 inhibitors without the metformin, but it is a diamond, so it is better to use.
I am so perplexed. So I will take the help of audience. How many people to continue metformin as a first line?
Metformin always will be good. Metformin is I also.
Anybody to give SGLT2 first? Yes, there is a. So we had a very interesting debate, and I congratulate both the debaters. And with this, we end this session.
I will request Vidyut sir to felicitate both the speakers.
In my most of the talks, sir, Vidyut Bhai is my chairman.
If you permit, I have just one data to share. Favoring Dr. O, honestly.
Sure.
So, the UKPDS post-trial monitoring results showed continuing benefit of earlier metformin therapy with maintenance of the relative risk reduction reported in 1998 for any diabetes related and 0.21% reduction, MI 33%, all p-values significant, and all-cause mortality 27%. So I think thank you both for highlighting that we need to wear a gold and diamond ring. Thank you.
Thank you, sir, and thank you, Chairperson, for the wonderful chairing the session. I request Dr. Jimit Vadgama to felicitate our chairpersons. So moving to the last session of our today's talk, we have Dr. Vijay Gadia from the Morbi, and we have Dr. K.N. Bhatt from Surat. Sir is not there. But sir is not there. So over to you, sir, for chairing the session. Thank you.
Good evening, everybody.
in last session of today's talk, I request Dr. Jimit Vadgama to present his lecture. I will be lucky to introduce him. He is having fellowship in endocrinology, diabetic and metabolic at MD Medicine. He is a consultant endocrine, diabetic and metabolic physician at Surat, co-author for RSSDI guideline for the in-patient management of hyperglycemia 2016, executive editor in RSDI textbook of diabetic 4th edition, 2019 Rising Star Award from the Indian Academy of Diabetes. So many felicitations and awards from him side. We will be lucky to have his talk on. Please continue, sir.
Thank you, sir. Thank you for the kind introduction. And I thank Sandeep Desai, sir, and Pradeep Joshi, sir, Pratap Jethwani, sir, for inviting me here after the wonderful debate, which also was in favor that SGLT2 inhibitor shouldn't be started first. Majority of audience agree. One of the reason, lecture change. Majority of the audience, they said they won't start SGLT2 inhibitors at first. Why? Because of the troubling mycotic and genital infections. So this is the reason, one of the most important reason why we are not starting it. So I will be discussing on the common genitourinary tract infections, and we all know genitourinary infection is the most common bacterial infection among diabetic patients. If you see, around 60% increase in the risk of urinary tract infection is there if your patient is diabetic, and also there is 2 to 4-fold increased risk of genital infection is there if your patient is diabetic. Very important thing, and why we want to discuss, because these diabetic UTIs, they are usually multifactorial in origin, and risk for infection is associated with longer the duration of diabetes, more the severity, and how uncontrolled your diabetes or how severity of diabetes is there, it leads to more UTI and genital infections. Yes, it's more. So what are the reasons? Yes, we all know high blood glucose concentration is there, which is the nutrition for bacteria that are lying in our urine. There are more immunological defects are there, and your patient is uncontrolled. There are bladder dysfunctions due to autonomic neuropathy. Long-term uncontrolled diabetes leads to diabetic autonomic neuropathy also. And we all know bladder is one of the important organ to be affected by autonomic neuropathy. And that's why it leads to bladder dysfunction, and very importantly, incomplete voiding of urine. So that's staying of urine in the bladder. It's again a reason why UTI are more common. And also there is dysfunction of chemotaxis and the phagocytosis at the leukocyte level that leads to bacteria flowing up. So these are the common infections. These are which are more commonly found in diabetes, like emphysematous pyelonephritis, emphysematous cystitis also, and prostatic abscess. There are also common infections, but which are more complicated in diabetic patients, like asymptomatic bacteriuria, acute pyelonephritis, perinephric and renal abscess, Fournier's gangrene, papillary necrosis, balanitis, vulvovaginal candidiasis, and there are fungal pyelonephritis also and fungus cystitis. We will be seeing few of the common ones and discuss few of the peculiarities of that. But very important thing, these are the common organisms. So E. coli and Klebsiella are one of the commonest organisms for UTI. For balanitis and balanoprosthitis, and candida is again the commonest one. And for male accessory genital infections, enterobacteriasis, we can also have Neisseria also, chlamydia also. These are rare organism, but very uncontrolled diabetes, we see this male accessory gland infections also. Vaginitis, again candida is the commonest one. What are the methods of urinary sample collection? So we all know midstream clean voided urine, usually preferred is the morning one. The first one is the preferred one, but important thing is when we are suspecting the infectious disease specialist, they are also advising this. After cleaning the gelatinea with betadine, you should collect the first morning sample, the midstream clean voided urine. Aseptic bladder puncture is again another method for collecting urine sample, very rarely used. Catheter tip culture, we all know it is a controversial method, but in ICUs and hospital
admitted patient, it is frequently used. A colony count of more than 10 raised to 5 colony forming unit per ml is of 1 or 2 organism is considered significant. So diagnosis wise, if you are suspecting vaginitis, cervico-vaginal swab can be done with drug sensitivity test. For UTIs, we all do urine culture. For balanitis and balanoprostatitis, there is usually urethral swab culture with drug sensitivity testing, but it is usually very sensitive to fluconazole and other azoles. So usually the culture is not required, but for recurrent infections and severe infection, it is frequently sent by ID specialist. So male accessory gland infection, we do semen analysis, semen culture also sometimes. Prostatic and vesicular and sometimes didymal and epididymal ultrasound scan is also helping us in the diagnosis. So combination of therapy is again needed. So what happens sometimes, only antibiotics, they are insufficient. In complicated and long standing and resistant UTI, sometimes we have to give combined therapy. So it is needed very less, but the urologists, they frequently use these two other combination apart from antibiotics. So these are anti-inflammatory drugs, salicylates, profans, COX-2 inhibitors and sulfonamide have also some anti-inflammatory actions. Fibrinolytic drugs were used very commonly previously by urologists, sometimes now also, like bromelain escins, but nowadays with the endoscopic technique going more and more, it is used less and less nowadays. So coming to one of the most serious one and very rare but very commonly now we are seeing emphysematous pyelonephritis. So it is a necrotizing infection of renal parenchyma and its surrounding area that results in presence of gas. So whenever there is gas in your CT scan, you are suspecting, always it's kind of like a medical emergency, either in the renal parenchyma collecting system or even in the perinephric tissue also. And around 85 to 100% of diabetic patients. So if you see all patients presenting with this condition, 85 to 100% you can suspect diabetics. Approximately 40% have some kind of obstruction like calculus, and in 10% cases it is bilateral. Usually the common presentation is fever, flank pain, pyuria, similar to any pyelonephritis, but it can also present as a complicated case of shock and altered sensorium. So whenever your patient with UTI, if the fever doesn't subside for few days of antibiotic, think of some papillary necrosis, renal abscess or this emphysematous pyelonephritis, again very important thing. So and we all know whenever there is acute renal failure, it is a poor prognostic sign along with shock, thrombocytopenia, altered sensorium and severe proteinuria. So there is a CT guided classification is there, we can classify the severity. Management is usually team approach. We also usually this cases, as we have seen, is associated with acute kidney injury, so we have to involve a nephrologist also, and sometimes we see if it is more progressing, we have to involve a urologist also, because if we can see the later classification, they may require surgical intervention like nephrectomy also in the very severe cases. So broad spectrum antibiotics is required, aggressive glycemic control is the must, and adequate hydration according to the EGFR or the urine output statin we have to give. Antibiotics like cefoperazone, sulbactam or piptaz is the preferred one initially, and if ESBL is suspected, we can also give carbapenem. For glycemic control, we have seen, and you must have also been encouraged when such kind of patient with shock and septicemia, we have to give some large amount of insulin doses to control sugar. Even IV infusion we can give up to 20 to 30 units per hour also in such kind of patients. So surgical intervention is required. As I said, you need to call urologist whenever you are suspecting. Okay, the time is no money and time is kidney here, so we have to save it. So if we find we can we can save it if we diagnose early and treat aggressively. But sometimes we have to see day-to-day progress and discuss with urologists and to conservative manage this patient. But sometimes they have to intervene, and some of the class 3A, 3B and 4 also, the patient may require a total nephrectomy also. Abscesses are again very common. You may have encountered renal and perinephric abscess. It can develop either renal cortical abscess also or renal corticomedullary abscess also. So patient with usually fever and flank pain, and usually there is a mass. So always your UTI patient, you must examine the renal angle. We have been taught in our MBBS that about the palpation of the renal angle. We have we may feel a mass there also, we may feel tenderness also. So CT and USG are diagnostic, and treatment again include antibiotic. We may have to do percutaneous drainage also, or nephrectomy. Very rarely we see renal papillary necrosis when we should suspect in patients who have frequently relapsing or difficult to treat pyelonephritis, and also in those with fulminal presentation with hematuria. So there may be either renal colic also due to the actual renal papilla passing into the urine, and majority of the cases are seen in women. Diagnosis depends upon the demonstration of papilla or abnormalities without focal renal loss, and treatment again is similar. Very rarely in males we see prostatic abscesses also, again very common nowadays. With the majority of the patients, we have seen large number of uncontrolled patients, and we are getting more and more diagnosis because of the early investigations. So it is rare, but definitely found most exclusively in diabetic and those with prolonged catheterization. Again a very important thing which urologists manage. Prolonged catheterization is again a predisposing factor for prostatic abscess, and it should be suspected when there are recurrent and persistent symptoms of fever, dysuria also, along with very important thing, patient have urethral discharge despite you are giving adequate antibiotics. So always suspect that. Digital rectal examination may show fluctuations, and the transrectal USG also helps. Culture after prostatic massage can help to give the proper antibiotic coverage idea, and treatment is antibiotic only, and sometimes we have to drain also surgically. Candidiasis in the renal tract, again very important thing. We are seeing nowadays more and more cases of diabetes are going up, and we have now diagnostic abilities are also available for fungal infections. So Candida albicans, and sometimes less commonly Candida glabrata infection is again very common in diabetes, and with the increasing use of broad spectrum antibiotics, the Candida is again growing back, and again this is a predisposed to patient with indwelling catheters and long standing catheters. Many of the patients may be asymptomatic also, or they may present with any of the complication. Diagnosis is by urine culture with 10⁵ colony forming unit for Candida. This is very important thing, and treatment is by either fluconazole and sometimes amphotericin B we have to give parenterally. Fungal ball sometimes seen in urinary tract, they may need to be removed by the cystoscope also. Very interesting, we have been taught and we have been seeing in the medical colleges, and again that this condition came light with the SGLT2 inhibitors, is the Fournier's gangrene. Practically we see very less in our clinical practice in city areas, but rural areas and medical colleges we have been seeing these cases. Again a necrotizing fasciitis that occur around mid genitalia. There is pain, swelling, crepitations, screen breakdown with overlying bullae along with signs of toxicity. Testicles are usually spared because of the separate blood supply, but treatment is very important thing is the early and wide surgical debridement along with broad spectrum antibiotics. And again crucial thing again similarly here remains is the good glycemic control. For IV infusion we may have to give larger doses of insulin. Very important thing is the mortality. Again it is very high, 40 to 50% even with aggressive treatment. So again this is kind of medical emergency. Very commonly we are seeing now vulvovaginal candidiasis with the increasing use of SGLT2 inhibitors also, and more sexually active females are becoming diabetic now. So we are seeing this complication very commonly, and women are more and predisposed to these infections. Vaginal epithelial cells, they also bind to Candida albicans with greater propensity in diabetic patients than non-diabetic patients. Treatment topical is the first choice, and it is usually very easy to treat if your patient is well controlled for hyperglycemia. And balanitis and balanoprostatitis again very commonly seen. Usually what we see, either a newly diagnosed case of type 2 diabetes comes with a male comes with diabetes, or patient with SGLT2 inhibitors. So we are now frequently seeing this in our OPD, and the commonest organism is Candida, and therefore an antifungal should be always be prescribed. So what we are seeing GPs, they are giving just antibiotics and local creams with even steroids. So this is the important thing, that antifungal should be always be prescribed in diabetic patients with balanitis or balanoprostatitis because of this fungal nature. Very rarely tuberculosis, genitourinary tuberculosis again still found in our country. Okay, it accounts for around 80% of disease burden in India, and even 18% of infertile women suffer from it. So this is again a big number. We are seeing more and more patients with IVF. We have to seeing this number high. So urinary tract tuberculosis account for around 4% of all infections of urinary tract infection in India. Again, very common thing. So principles, they are very similar to those in the pulmonary tuberculosis, because it is also considered severe form also because of these two reasons, because the bacterial load is very high in both of these, and secondary, if not treated aggressively, it can potentially result in irreversible structure and functional damage like infertility we have seen. Very important thing for fluoroquinolones when we are suspecting TB, because all fluoroquinolones have very good antimycobacterial activity. So if you give this as an empirical treatment to all UTI, you may mask the presence of genitourinary TB, and you may detect it very late stage, and thereby delaying the diagnosis, and also you may result in resistance also. Last part, very important thing, due to SGLT2 inhibitors. So this was the topic of debate initially. So genital infections are more common. If you see all the meta-analysis, and we have seen with Kana, DAPA, EMPA, TOFO, all meta-analysis, they say diabetic patients are treated with SGLT2 inhibitors, they have increased risk of developing UTI as compared to those diabetic patients who are not using SGLT2 inhibitors. So clearly meta-analysis is in flavor, and we all have practical experience. So currently increased use of SGLT2 inhibitors in clinical practice requires an analysis of urinary disorders such as excluding the presence of UTI prior to the treatment. Again, this is a very important thing. So how we can prevent it? Genital hygiene, we all know. Adequate hydration is again important thing. And if symptoms of urogenital infections, patient should be taught to report immediately to prevent the progression of the infections. So for perineal hygiene, washing of the genital organs is very important after urination or defecation. Women should all be advised to wash from front to back. This is again, we should all teach our female diabetic patients to maintain this hygiene, and the direction of the wash should be from front to back. And uncircumcised male should retract their prepuce before wash. Use clean water for washing or mild soap if it is required. And remember, alcohol-based disinfectant should not be used. So treatment is usually very simple. Uncomplicated candidal vulvovaginitis is there. So topical antifungal agents with we can give, or a single dose of 150 milligram of fluconazole is adequate. Okay. With severe acute candida vulvovaginitis, we may give to every 72 early 150 milligram for 2 to 3 doses also. Recurrent vulvovaginitis for 10 to 14 days of therapy with topical agents, followed by fluconazole 150 milligram weekly for even 6 months, we may have to give. So take home message, to reduce the risk of recurrence, combined treatment including antibiotic, anti-inflammatory and fibrinolytic molecules we may prescribe. The choice of anti-diabetic drug to prescribe should be taken into consideration in presence of urogenital infection. We already discussed in the debate, and urogenital infections are more likely to lead to complication in diabetic patients than non-diabetic. So always take care at an emergency time is kidney also, as we know, and leading to a healthier lifestyle. Managing diabetic mellitus with a patient-centric approach from the outset are most putative methods for preventing critical long-term genitourinary manifestation of diabetes mellitus. Thank you.
Thank you very much, Dr. Jimit Vadgama sir, illustrating the big topic in a short time, genitourinary infection in diabetes mellitus. We can have one or two questions if we have.
Yes, sir.
How do you take the decision about reinstating that particular SGLT2 inhibitors after how many, in case of recurrent infections, or suppose one single infection the patient has had, you have discontinued the SGLT2. First, how important it is to discontinue, and if at all you have discontinued, when, and if you take this thing of reinstating.
So actually there is no clear-cut guidelines for that, but simply think, if the infection was mild and it was easily treatable, and after patient has been taught about the hygiene hydration part, you can restart it. If it is recurrent, then you definitely have to stop. Also, once the patient is developing pyelonephritis and acute kidney injury, usually we do not start. If the patient's complicated status like calculus or any stricture, urethral stricture has not been cleared, we don't start it until it is very clear, sir. Yeah. And also bladder issues also and prostatitis. If they are not rectified, don't use it.
I request Dr. Vijay Gedia sir to felicitate Dr. Jimit Wadkama.
Our next speaker is Dr. Sandeep Desai sir. He is going to talk on defining TIR goals in the clinical practice, alternative targets. He is MD from the GMC Surat, diabetologist, PG diploma in diabetes from Cardiff, UK. He is the secretary of RSSDI Gujarat State Chapter and chairman of Advanced Diabetic Care. I request Dr. Sandeep Desai sir to go on for the next lecture. Thank you.
Thank you. Thank you, Vijay bhai. I am glad that at least there is some audience listening even in the second last lecture. And I think this is good. Even in national conferences, we have not seen more than this. I guess everyone is using CGMS, or are there anyone who are not using CGM or infrequently, or they are not in favor of using CGMS? So Jimit is there. All else are using frequently CGMS. So that is because, see, for Sushil or for someone who is using CGMS, this is not the lecture. I am trying to give a very, very basic lecture so that at least if 3 people are convinced by this presentation, I would be more than happy. So this is a HbA1c era, we all know. The main glycemic metric for guiding therapy changes. It is for rating the quality of diabetes care, for diagnosis, for monitoring. It's a standard marker for knowing the risk of complication. If it is good, the complication is less. All the guidelines, all the therapy are targeting the A1C. All the guidelines that A1C should be less than 7 with this drug, 1.2 reduction of A1C with this drug. And the main outcome marker for FDA and EMA approval of new glucose lowering drug. So that should lower some A1C, then only you are approved as a glucose lowering drug. So we all know that it's an HbA1c era, and we are trying to go somewhere else. So this is one blood glucose monitoring which we normally do in a patient who is on insulin. And what has happened is, if you see, this was done in the wake up, and then on lunch reading was there, and then a dinner, and then at bedtime. So whenever this is as simple as whenever you go to a theater and you see a photograph there, and you don't understand what is happening, and that this is as simple that when you do a glucometer reading, this is what you get in a person, and the A1C is still high or the readings are not good, and this is what the actual picture is. So you are missing the hypoglycemias, you are missing the hypoglycemia down there, because this is not measured when the patient has it. You are also missing the upside, the hyperglycemia. So this is what actually the picture is which we are missing. So if you see the whole picture, then only you will be able to understand what the CGMS is, what the daily patient has to go through, a diabetic patient who is on insulin or not on insulin. So this is a typical, the red which is you are saying is a volatile thing, a very variable thing going up and down, and the green one is in range in between the 2 lines. So actually the green one also, as well as the red one, both have the same A1C, which actually the previous speaker also showed that with the same A1C you can get different time in range. And so A1C actually is not capturing the hypo and the hyper which we want to see in a real diabetic patient in a real life. What is time in range? It refers to the percentage of a time that person spends with their blood levels in a target range. So this is actually 70 to 180 is normally kept. And then there is a percentage of time above range and time below range also. And this is what normally, this is a 6.8, estimated A1C is 6.7, and so good. But actually if you see the AGP, this is the AGP, and the graph is so variable. There are a lot of hypos, starting from hypos and hyper in between, and then again in the night the patient is having hyper, hypo both. So variable. The coefficient of variation is very high here, more than 50. So this is what normally the AGP shows. It's a 24-hour graph of the 14th day, intraday as well as intraday. In one graph you can visualize what is happening to the patient. So this patient is actually not good, though the A1C looks good. So normally what do we want? We want a flat, narrow and in range. This is called FNIR. This is a new terminology for the AGP. So initially if you start with the left up, it is, flat, all are red, flat, narrow and it is not flat, it is lot of broadness, the narrow is not there, and in range it is almost above that line which is there. Most of them is out of range. Similarly, here if you see, it is slightly flat. If you see the blue line, the median, which is called the median, is slightly flatter, but still it is not narrow. There are a lot of variabilities and not in range. Lot of hyperglycemia is there. Here again the same thing, it is flat, slightly narrow, but still not in range. More hyperglycemic exposure is there, and this is what actually we want. The right down is the flat, narrow in range, and that can be achievable if we use a proper technology and if you use the our proper clinical as well as the judgment, as well as we monitor the patient properly. So this is what normally we want if you use a CGMS. So there are limitations of A1C, and even in US 51% of the patient overall less than 7% of A1C, and recently HbA1c is getting worse. It does not identify two things, and that is hypoglycemia or glucose variability. Patients come to you at the end of 3 months, you just have an A1C, nothing in between, and it can have some accuracy problem in terms of hemoglobinopathies, iron deficiency anemia, CKD, liver disease. Then there are genetic or racial differences also. So it does not tell the full story of glucose control. So we want something beyond A1C. This is a comparison. It evaluates single A1C level. The time in range evaluates continuous levels. It compares at 3 months apart. Here we get fluctuations of the day, intraday as well, and does not capture hypoglycemia. That is what is the biggest problem in diabetes patient, or hyperglycemic level occurring the same day, and captures all this time in range, captures all the glucose level for the given time frame and identifies time within a safe range. And of course it is less likely to capture impact of acute intervention. So what happens when you do a A1C, and if it looks good, we tell the patient to come after 3 months. So that 3 months we are not able to understand what is happening with the patient, and we cannot do any acute. Even if you add something, if you add a DPP4 inhibitor to metformin and you call after 3 months, we are not capturing anything. Here you capture in time in range the impact of acute intervention, including lifestyle, including some પૌવા ખાધા સવારે તો એનું બપોરે કેટલું આવશે તે આપણને ખબર પડી જશે. So dynamic, and so you can capture daily changes. If you have given some SGLT2 inhibitor, after 3 days you can see that changes of time in range, the glucose which can be seen. So it has now been standardized. Recent guidelines update towards the standardized CGM matrix. 10 CGM matrix are there. The time in range, time below range, there is level 1, level 2, and then there is time above range. And today I'm just going to talk is on spatial populations. Like besides the A1C, as we see that garden variety type 1, type 2, we want it at 7. But then there are older populations, there are pregnancy patient, pre-diabetic patient. So that is what I'm going to talk. So this is the standard you have seen in most of the conferences and everywhere, that a patient who is young, new onset, diabetes, no complication, no hypoglycemia, no comorbidities, then 7 or below 7. But if the patient is older, has comorbidities, has frequent hypoglycemia, less resources, no support system, probably you have to lessen the target, and probably 7.5 to 8 is okay. So this is what with the A1C we know. The same thing whether we can put it into the CGMS. So these are all the CGMS we are doing. The Abbott Freestyle Liber is the most common now. It is Pro as well as for the patient, and the Medtronic Guardian Connect. These are the common use, and these are the CGM TR target for most individuals. So for the 70% individuals, we can say that the TR, the green, is greater than 70%. What is 70%? 16 hours and 48. You can approximate say that 17 hours this TR. Most of after the 24 hours, most of the that is 17 hours it should be between 70 to 180, and then time below range allowed is less than 4. Less than 4 is 1 hour, and less than 1% is 15 minutes. Similarly, time above range, that is greater than 180, level 1 time above range, 6 hours can be allowed, and time above range greater than 250, 1 hour, 1 hour, 12 minutes. So this is the normal for any type 1, type 2 diabetes, most of the patients. But then there are patients who are older patients who are pregnant. So what about them? And here, of course, the target is 70 to 180. So how did this figure come? So with all this technology, finally what they found out was, with the hybrid closed loop system also, around 75% of the readings were in target, plus the complications with time in it approximates with 7% A1C also, as well as the complication time in range 70%, that is 17 hours in a day, is less compared to when it goes below the time or above the time above range increases. So older patient, this is one category where we cannot go so strictly. So here, if you see the right side, they are high risk patient, they are older, they have long duration of diabetes, they are on insulin uses, they have impaired hypoglycemia awareness, and probably they can get cognitive deficits because of the hypoglycemia, joint problems, they can fall and have fractures, CVDs, arrhythmias can occur because of hypoglycemia. So here we can target the target range, again the same 70, 180, but at least only 50% or greater than 50% is allowed, and you can allow hyperglycemia of around 50%, but hypoglycemia should be eliminated almost less than 1%, that is not more than 15%, and that too less than 70%. So this is how in older patient you have to take care of, because it's a different category. They have feeling lows and forgetfulness, falls, there are a lot of functional changes, finance problem, multiple medication, they are on 10 to 15 medications, so that is again affecting them. So this was a study of wisdom study in type 1 diabetes patient greater than 60 years, and what did they found with CGM or BGM for 6 months? So CGM, they found that the time below range, which we are worried about, or less than 70, was reduced to half, from 5.1% to 2.7%, and time in range as well as A1C significantly improved. So CGM definitely helped this patient compared to, if you see the BGM, that is blood glucose simple blood glucose monitoring, there was no change, 4.7 to in fact 4.9%. So that is what happens if you use CGM in patient, you can reduce the time below range. And again, the diamond study, this is with type 2 diabetes patient, lower A1C, higher TR, higher satisfaction. They are satisfied by using this, because then they get less hypoglycemia and they get some feeling of that they are doing something. And 97% use CGM 6 or more days per week at 6 months. So this is what happened. So the society also recommends that some form of monitoring is needed in patients who are greater than 65 years because of hypoglycemia, CGM being better. And this is what now gradually it is coming, the colors will also be more there. So what we want in this patient who are older patient, less red and more green. So this, if you see this, this is going to come now in the CGM. By color way we will be able to identify, and rather, because for a physician to identify sometimes it is very difficult. Normally it will be just like ECG. If you go on doing CGM, ECG આપણે પહેલા જોતા હતા ત્યારે 10 મિનિટ લાગતી હતી ને હવે 2 જ મિનિટ લાગે. અત્યારે હવે હું આટલા બધા કરું છું કે ઋતુલભાઈ કરતા હશે તો we take only 4-5 minutes to interpret the whole CGM, the daily glucose summary, everything. So this is just a case of 82-year-old, time in range 74%, but time below range is very high. So it is around 15%, and he was on basal insulin and low-dose sulfonylurea. He has CKD, so probably metformin was withheld, and you can see the graph, almost the below, that is hypoglycemia is too much, but he was taking just SMBGs, and what happened was it was around 150 one times and 170, and he informed his doctor, and doctor increased the basal insulin. So what happened was he got nocturnal hypoglycemia again, and that is what we want to prevent. If he has chosen to use CGMS, probably he was actually over basalized. They so focus on less red, hypoglycemia should be less first, and then try to increase the green, that is the time in range. And in fact, no CGM in this kind of patient who are type 1 diabetes or type 2 diabetes on insulin, especially LDL, is a risk factor. So CGM should be one of the armamentarium. And avoid overbasalization. Insulin needs frequent titration, we know, and actually he needed de-escalation of many medicine to minimize hypoglycemia. What about pregnancy after older? Pregnancy is one thing which we are still, there is a gray zone. There are limited data, but still for type 1 diabetes, the data is that it should time in range should be greater than 70%, that is 17 hours. The same time below range should be less than 4%, and time above range should be less than 25%. But if a patient is having gestational diabetes or type 2, we can go for stricter control. More the control, better for the patient. So you should tell the patient that after 70, every 5% increase in TIR is clinically significant. So try to go on, you can go on to 80% also, 85, as long as hypoglycemia is not a problem in this kind of patient. So pregnancy, we can go for more stricter targets. This is how time in range in trimester 1, trimester 2, trimester 3, and what the CGM target is greater than 70%, less than. This is the study of continuous glucose monitoring in type 1 pregnant patient. But what has happened is actually pregnant women with type 2 currently spend almost 12 hours only, 50%, 13 hours and 55%, and 14 hours in the target range of course, remember the target range in pregnancy is 63 to 140 and not the 70 to 180. So that is what normal person for a pregnancy, it is 140. Everything should be below 140. A 5% lower TIR and a 5% higher TAR. TAR is time above range during the second and third trimester is associated with increased risk of LGA infants, neonatal hypoglycemia, and neonatal intensive care unit admissions. So for optimal outcomes, all women and clinicians should aim at a target in range TR of greater than 70%, that is 17 hours, remember, and the target at least encourage them that every 5% increase in TR is associated with clinically relevant improvements in the neonatal health. So not well studied or validated, but target will depend on, as I said, type 1 diabetes, type 2 diabetes, gestational diabetes, and of course downloading of CGM data by the patient, easy review by you and your diabetes team, all will help later on. And because this patient requires insulin titration every 1 to 2 weeks, you cannot call the patient after 1 month, the pregnant patient. You have to continuously monitor this patient and titrate as frequently as possible. Whether for pre-diabetes CGM is there or not, right now the NANS data says that looked at 6 different ways to diagnose pre-diabetes: FPG, A1C, 2R HPG, FPG with A1C, FPG with 2R APG, and A1C with 2R PG. But the best possible was FPG, and A1C was the most sensitive to detect, but still it is not perfect. There are yet now data not available for CGM, but probably in future we might use CGM for the diagnosis of prediabetes. So as we are moving in the era. Again the same thing, if A1C is not reliable in this kind of patient where remission we are planning, then again the same estimated A1C less than 6.5 can be used in the CGM values. When we see the CGM, there you get a estimated A1C, or now it is called the glucose management indicator. So this is one step ahead. So right now we are targeting, the target is 70 to 180, but we want to still be tight if it is possible. So with the availability of the new drugs, the tirzepatide study, the SURPASS study showed that you can go on to the A1C of 5.82 without having hypoglycemia. So probably the main aim is to control but without hypoglycemia. So now the target can still be probably in the future reduced to 70 to 140 even in normal individuals. And the TITR, so now it is called time in tight target, probably that can be increased. And if you see the graph above the line and that is below the line, almost with tirzepatide, all the readings were in below 140. So you can get that also with these newer drugs, the SGLT2 inhibitors, the tirzepatide and the oral sema. So probably without causing hypoglycemia, we can put the strict target of time in target range of 70 to 140 also in the future. So these are the different glycemic targets for different population. As I said, 70 to 180 for the normal variety population. The older adults again greater than 50% only, and less than 1% hypoglycemia. The type 1 diabetes the same as almost type 1, type 2, but in pregnancy with type 2 and gestational diabetes we can go on increasing to 80-90% also. Summarizing, this is a summary slide of all the 4 things. So probably it's time to move on. So actually TIR is written in conjunction with A1C, but TIR should be here. So probably right now we are in the A1C era, gradually we are moving, and probably a time will come. Right now what I am doing is I do A1C once and once CGMS if the patient is affording. Sometimes the affording problem is there because patient will not, and almost that can be done 3 months A1C, 3 months. So that is what we are going to do, and probably an era will come when TIR will be one of the main rather than A1C. So time in range is standardized, still needs to be individualized. Tighter targets may be appropriate in pregnancy, newly diagnosed and younger patient. As I said, 70 to 140 also we can put it. An emphasis on hypoglycemia avoidance may be more appropriate in elderly and high risk patient. So more research is needed for additional population like children, teens, inpatients. Still there are not data, those with complications. And of course the advancement in technology as well as the drug will likely shift our TIR targets to a tighter range, and having cloud based easy access to CGM data and EHR integration will also improve our understanding of TIR. I think this is the last slide. So we all know it's inversely correlated to the risk of developing micro and macrovascular complication in diabetes. Thank you.
Thank you very much, Dr. Sanjeev Desai sir. Now I request Dr. Rutul sir to facilitate Dr. Sanjeev Desai sir. Now let's move to the last lecture of this session and entire today's lecture series. Now I invite Dr. Sushil Patel, consultant diabetologist, Aksar Diabetic Center, Vadodara. He will be talking on exercise prescription in diabetes mellitus, tips for the clinicians. This is the very interesting topic, and I hope all physicians will love to hear him. I request Dr. Sushil Patel sir to please start your talk.
Thank you, sir. Thank you for kind introduction. So I am the last batchman. The topic is also very energetic, exercise. So exercise prescription for the diabetes, tips for the clinician. So why the physical activity is needed? Sedentary lifestyle is one of the major risk factor for the CVD, independent of the participation in the physical activity. Physical activity has a positive effect on the hypertension, dyslipidemia, body weight and the diabetes, and regular physical activity reduce the risk of all cause and severe mortality in the healthy individual by 20 to 30%. So this is all and above all the CVOT trials what we had seen. Because the drugs may not be that much effective, what the lifestyle modification can do in the subject with the coronary risk factors and in the cardiac patients also. So benefit of physical activity in diabetes, it improves the glycemic control, it improves the body weight, greater muscle strength, improves the insulin sensitivity, it increases the cardiovascular fitness, and the structure aerobic exercise or resistance exercise reduces the HbA1c by about 0.6% to 1.6% in the type 2 diabetes patient. So how we classify the exercise? Aerobic exercise are endurance type exercise, rhythmic, sustained for sometimes like the walking or the jogging, running, swimming, cycling. And the another form is the resistance exercise like the bodybuilding, weight training exercise, free weight, machine, elastic ropes, calisthenics, and the flexibility exercise are the stretching exercise. So recommendation for the physical activities in the diabetes, ADA, ASD guidelines and ASC guidelines has shown that more than 150 minutes per week of moderate to vigorous intensive physical activity is recommended. 2 to 3 sessions per week of the resistance exercise on non-consecutive days combining the aerobic and the resistance training have a more favorable effect on the glycemic level than the either alone. 2 to 3 times per week of flexibility training and the balance training recommended for the older adult with the diabetes, and the prolonged sitting interpreted every 30 minutes for the blood sugar benefits. So 2 years study was there that after the 24 months of the intervention, incidence of type 2 diabetes were significantly decreased in the patient, where 74% decrease in the where the aerobic activities and the resistance training was done, 65% in the resistance training group and the 72% in the aerobic training groups. So cumulative type 2 diabetes incidence were significantly reduced in the either the patient is doing the any kind of exercise, either it is a combination of both of these aerobics and the resistance training, or it is only the resistance or the aerobic training. So response to the 100 gram of glucose in the mild type 2 diabetic. So you can see that after ingestion of this glucose, if the person is doing the 12 month of training, you can see that there is a very good response before the started of the training, after the started of the training. You can see a significant amount of difference, and the response to 100 gram of glucose in the form of plasma insulin level also, you can see a significant response after the 12 month of the training. So regular exercise is the key in the management of diabetes. So how we measure this is a metabolic equivalent, the amount of energy expenditure during the exercise. The amount of energy expenditure expended during the exercise related to the energy expenditure during the race. So if we see that energy expenditure during the race is 1 MET, that is equivalent to 3.5 ml of oxygen per kilogram minute and the 1 kilocalorie per kilogram hour. दोस्तों डिस्टर्ब करो बंद થઈ ગયો ચાલુ લેક્ચરને કેમ ડિસ્ટર્બ કરવાની જરૂર પડે છે. So physical activity intensity in the MET, light that we call as a less than 3 MET, moderate 3 to 6 MET, and the vigorous above 6 METs. So moderate activities can include the brisk walking, recreational swimming, volleyball, slow aerobics, moderate cycling, gardening, double tennis or badminton. And the vigorous exercise can involve the jogging, running, single tennis, basketball, rope skipping, squash, fast aerobics, fast cycling, stepping, soccer. So what I want to highlight is that it is not only about the walking. So whenever the patients comes in our chamber, then we generally ask ketlu chalo cho. So whatever it is, whatever kind of a moderate activity exercise a patient can do, either it can be a brisk walking or the swimming or the volleyball, aerobics or the cycling, or even the gardening, can help that patient to control the blood sugar level. So energy expenditure, the energy cost in the various activities, that is per kilogram of body weight, this brisk walking per minute. So you can see that brisk walking is maybe lesser than the running. The running 7.5 minutes per kilogram, and the swimming is almost more effective than the brisk walking. So don't advise only that you should go for the walking. Why? Because many of times your patient is suffering from the knee joint pain, and they only argue that I am not able to walk. So the swimming can be a better option for them, or even the another kind of exercises can be a better option for them. So how to calculate the energy expenditure during the brisk walking? So what you can calculate is that is equal to 0.07 kilocalorie per kilogram of body weight per minute. So if the patient is of 76 kg, would expend 0.07 into 76, that is 5.3 kilocalorie per minute with the brisk walking. Now if he has to expend 1200 kilocalorie per week, then it is a 1200 by 5.3, that is 226.4 minutes. That is equivalent to 45 minutes per 5 days per week. So if this patient of 76 kg is doing the 45 minutes of brisk walking in the 5 days a week, then he is spending a 1200 kilocalories. Preparing a patient for the exercise, proper warm up is always an essential thing. 5 to 10 minutes of aerobic activity is the essential. So guide your patient to do a proper warm up. 90% of the patient do not do a warm up and they may end up some of the muscle injury. Activity session of 15 to 30 minutes or even up to 1 hour, maybe depending on the patient's capacity. And the cool down period is again, that is also the same importance, like, and it should be the structure like the warm up period of 5 to 10 minutes. So exercise should be done according to the FIT principle: frequency, intensity, type of exercise, and the time. Maybe the morning or the before the dinner is ideal time. So this can be the structure program what you can may convey to the patient. Like if the patient is not doing any kind of exercise, then you can start with the 5 minutes of warm up, 5 minutes of brisk walking, or 5 minutes of cool down period. If the patient has a lesser ability to do, then you can straight away start with only the 5 minutes of brisk walking. Then you can gradually increase in the second week 7 minutes, third week 9 minutes of brisk walking. So this can be the beneficial. You can go up to the 1 hour depending on the patient's capacity, but it should be before and after 5 minutes of warm up and the cool down period. So what is the amount of physical activity that is recommended to promote the health? Moderate intensity physical activity, energy expenditure 3 to 6 MET, that is more than 30 minutes per day or more than 5 days per week. 150 minutes per week should be minimal, and more than 1000 kilocalorie per week should be expenditure. How can you begin? Choose an activity what you want to do. So this is a common question which is asked to the physician or the diabetologist. Sir, what kind of activity I can do? So this decision should be the combined decision of the patient and the doctor, not only the doctor. Set a long-term goal, at least 30 minutes a week, 3 to 5 days a week, and buy a comfortable walking shoes. Get a partner. That is again the important, because if you are doing the alone, then it may stop very much in the short time. But if you are doing with someone, then it will continue for the long term. So stretching is important. Getting started, if you are more than 35, have diabetes of more than 10 years, or have high blood pressure, heart disease, poor circulation, or any other diabetic complication, then patient should first consult the doctor. Type 2 diabetes more than 10 years or type 1 diabetes more than 15 years, presence of microvascular complication, retinopathy, nephropathy, presence of peripheral vascular disease, all these kind of diseases needs detailed evaluation before starting the exercise. Some tips that always carry on the identification card with the patient: check your fit before the exercise. This should be the message to be conveyed to the patients. Choose a good footwear, light clothing, drink lots of water, don't exercise during the hot session and when not feeling well. So things that should be kept in the mind. Maximize the benefit and limit the risk. You should have some carbohydrate with you, and every 30 to 60 minutes of exercise you may take some 30 grams of carbohydrate. Replace the fluids. Monitor blood sugar maybe before the exercise and immediately after the exercise to avoid the risk of hypoglycemia. Proper food care is important, and avoid the weightlifting, specifically when the patient is suffering from the retinal injury or the glaucoma. Yoga are also good for the exercise. It can improve the digestion, circulation, and the immunity. Yoga enhances the function of neurological and endocrine organs, and it is helpful in the chronic illnesses. Some yogas that may be beneficial in the diabetes are the Vrikshasana, then the Dhanurasana, Halasana, and the Ardha Matsyasen. These are the yogas. I am not going in the detail. Quick workouts that can be done. Exercise at least 30 minutes per day. If you cannot do it on the one stretch, then it may be break up, but it should be less than more than 30 minutes per day. Increase activity in general, walking or climbing the stairs. Do not rely only on the household work. Majority of our Indian females are saying that I am doing the household work, so it is enough. It is not enough. So they have to spend some time in the exercise. Daily workout is necessary. Step that can be followed: fold every exercise in your day-to-day routine. Get off the bus maybe one stop prior to your home. Put the exercise bike in front of your TV or in the room where you are spending most of the time. Perform the exercise while in the bed. park the car in the far end or the parking lot, and you can walk away, join the gym or play some sports. So in the presence of hyperglycemia or the ketosis, you should not exercise. In the presence of hypoglycemia, you should first correct the hypoglycemia. For the diabetic retinopathy, recommended exercise are low impact cardiovascular conditioning such as swimming, walking, or low impact aerobics, stationary cycling, endurance exercise. Contraindicated are the strenuous activities like weightlifting or jogging or high impact aerobics or racket sports. In the nephropathy patients, low to moderate intensity forms of exercise are recommended, and the contraindicated are the high intensity form of exercise. If the patient is suffering from peripheral neuropathy, then there may be loss of sensation in the feet. So moderate intensity walking not contraindicated, but with the proper foot care and the daily examination of for the lesion is important. Foot injury cases or open sores, there should not do the weight bearing. Repetitive examination exercise on the insensitive foot can lead to the ulceration and the fractures. Limit weight bearing exercise like the treadmill or prolonged walking, jogging, that may cause some kind of ulcers. So diabetic with the autonomic neuropathy, in this condition may limit the exercise capacity and increase the risk of cardiovascular event during the exercise. Hypotension and the hypertension are more likely to develop after the vigorous exercise. Those patients may have difficulty in the thermoregulation, so avoid the exercise in the hot or cold environment. Encourage the adequate hydration. The hypoglycemia is the major concern in our patients when they are doing the exercise. So it will most likely occur in the patient who are taking the insulin or the diabetic pill, skip some meal or exercise for the long time or exercise strenuously. So if it occurs, what can be done? Patient must eat some snacks before exercise. Adjust the medication dose. Remember that patient should always carry a source of carbohydrate with them. So hypoglycemia management during the exercise, please remember that it is a medical emergency. Snacking to prevent the hypoglycemia, basic rule is snack prior to the activity to prevent the hypoglycemia. Adjust the quantity based on the pre-activity blood sugar and the or the direction of the blood glucose. If you are using this AGP or CGMS, snacks at least once per hour during the prolonged activity. Choose the high glycemic form of carbohydrate when you are correcting the hypoglycemia. So this may be the sample exercise prescription. So you can write down the patient's name and the date. As your healthcare provider, I can recommend that you can follow this physical activity prescription. Tick below. You can have some choices or you can write down directly that increase physical activity in your day-to-day routine or reduce the sedentary time. Begin the regular aerobic exercise. You cannot write that 150 minutes or this for each and every patient, but depending on the patient's activity level, depending on the patient's condition, whether he is suffering from any kind of complication, you can mention that this much of minutes or per day or this much of times per week they can follow this exercise. Begin the resistance exercise maybe 2 days per week. Again, this depends on the patient's condition and the complications. Continue to do the regular aerobic exercise maybe 5 days per week for the minimum of 30 minutes per session, and the continue to do the regular resistance exercise 3 or more days per week. So this can be the customized according to the patient, or you can generalize these things and you can tick mark over here. So this may be the sample exercise prescription. You can make your own by all your wisdom. So thank you again, thank you very much, and thank you to whole RSSDI team for giving me this opportunity. Over to you, sir.
Thank you very much, Dr. Sushil Patel, for excellent presenting the exercise prescription for the diabetic patient. We may have 1 or 2 questions if anybody wants to ask.
You regularly follow this prescription pattern in your practice?
For some patient, not for everyone. Specifically I prescribe when the patient is suffering from some kind of complications. Like if the patient is suffering from the retinopathy, then there are some exercises like heavy strenuous exercise should not be done. So specifically I mentioned that what should not be done. Otherwise that you can do the another kind of things. For the complicated patient, yes, it is always a complaint.
After prescribing,
Yeah. Yeah, definitely, because they are not aware about all these things. Maybe at some point of time they had visited the retinal specialist, but they had not conveyed the message what kind of exercise they cannot do and what kind of exercise they can do. So I always have the habit of specifically for retinopathy or the nephropathy or not nephropathy but the neuropathy patient, that this kind of exercise should be avoided and this can be done. Yeah. Motivating the patient that this kind of, but if I am doing this and I just change my lowers, if I am doing with the full track band or the half bands, then the same device is showing the different step with the same distance what I am covering with the same speed, with the same intensity. So I am doing the regular jogging, and for sometimes I had seen that for the 10 kilometers it is showing the 20 kilometers, and at the same time with the some other day it is showing the 5 kilometers. So depending on how fit this device, maybe the mobile, maybe the watch you are wearing, that is actually in the position to calculate that things. But definitely it is useful to motivating the patients.
May I request Dr. Sandeep Desai sir to facilitate Dr. Sushil Patel.
Thank you, sir. And we had completed the session over here. So
It's going on there, downstairs.
ના નીચે આપણે સેકન્ડ ફ્લોર પર છીએ. So thank you all of you for joining over here, and see you next year with the Diabetica 2023. And we have the validity function in the hall A, so we can all join over there. Thank you.